All right. Well, good morning, everyone. Thanks for joining us today for the MPJE Refresher session today. We're excited to have all of you here today, and our goal is really to help you all pass the MPJE. Just a note, if you're here today and haven't registered for the session, please register on the WSPA website. That is wsparx.org, so we can get you resources. And it's also for us to keep track of who's attending as well. So welcome. So for all of you, there's a mix of you in this group today. So welcome to all the UW students, Wazoo students, and also for all of the people coming to our state, residents and pharmacists who are here to learn about our state laws and taking the MPJE. So welcome to you all. If you have any questions about anything, by all means, feel free to let us know. What we're going to be talking about today, we'll do a quick introduction, a little bit about logistics, licensure applications, how to study, and then we'll be going through an interactive session today. So it's going to be questions that may look like questions from the MPJE, and we'll use those to guide us through today's session. So it's going to be interactive. We want all of you to participate if possible. And we'll have 4 different rounds. Those 4 different rounds will correspond to each of the different competency areas in the MPJE. And then in between, we'll have a 30-minute lunch break. So just a quick introduction. My name is James Lin. I am a clinical assistant professor at the University of Washington School of Pharmacy. I run the pharmacy law curriculum there. Um, Happy to answer questions if you want to send me any emails. I'm also a proud community pharmacist, practice in a community pharmacy setting as well. Let me turn it over to Boris to introduce himself.
Hello, everybody. My name is Boris Zhang. I am a pharmacist as well. My background more in academia. Some of you may have had me as a professor back at WSU, but my current role is Director of Professional Affairs for the Washington State Pharmacy Association. I am happy to get to host this session with Dr. Lin here. We did this starting last year. As part of the recognition from your RPDs that additional resources may be needed for MPJ review. So that's why we are hosting this session. So please be interactive. Feel free to throw questions into the chat. This session is meant for you. And note that this session will be recorded so it can be played back.
Thank you. And we also want to thank Dr. Brenda Mulatto, who's on maternity leave right now. So proud of her. But she also assisted us in the creation and development of this presentation as well. All right. So just a quick disclaimer. We are not the Pharmacy Commission, aka Board of Pharmacy. We're not affiliated with the NABP. So unfortunately, we don't have any questions from them directly. So our goal is to be a resource for all of you to pass the Washington State MPJE. Can't guarantee that it'll allow you to pass it on your first try, but please use us as a resource. We are here to help. One thing to also note, content in this presentation may change over time, shouldn't be used as legal advice because things change over the time. We are trying to do our best to make sure everything here is accurate. Again, contact us if you have any questions. So what are our goals today? 3 main goals: enhance your understanding and application of key Washington State pharmacy practice regulations. So this is a MPJE review for Washington State specifically. Though there are going to be many federal laws, we are focusing a lot of the content on Washington State related items. In addition, we want to provide you practice opportunities. So we're going to be presenting a lot of MPJE-like questions. This is a refresher, so it's expected that you've spent some time looking at the material already. If you haven't, it's okay. Let's have a conversation. And then really just have a good time exploring some law concepts together. So, a quick introduction to the MPJE. Our state's MPJE is difficult, unfortunately. There's a lot of questions that you will get that are scenario based, where you will be applying the knowledge rather than just simple regurgitation of what is presented to you or what the laws are. They'll have you apply them in different scenarios, sometimes in scenarios you've never heard of before or never thought of before. And the idea is to think about what concept are they testing you on and how does that apply to the scenario at hand. So a few areas that we've gotten feedback from other students about are controlled substances. Know your controlled substances very well. You've probably all heard of the DEA manual. I highly, highly recommend know that super, super well, including topics you may think may not necessarily be that important to study for. They may appear on the MPJE. So highly recommend know your controlled substances. Other areas that people have struggled or saw difficult questions, licensure, personnel, and scope of practice. So it's a good idea to know, as a licensee, what you can and cannot do, what your scope of practice is, what other practitioners' scope of practices are. Know about, say, transferring licenses, what to do if your license is expired, things like that. Prescriptive authority, as mentioned in scope of practice. USP and compounding always comes back, both in the MPJE and the NAPLEX. Prescription fill exceptions. Say you're doing a partial fill for a Schedule II controlled substance, or maybe there is an issue and there's a national disaster. How do we handle those kind of exceptions? And then also just think about areas about handling medications in a non-community, non-hospital setting. We think a lot about community and hospital because those are the two biggest, most common settings people practice in, but you're going to get questions on settings that are non-community and non-hospital as well. And think about which rules apply to which settings. In general, most of the rules are universal. So just think about that application. So resources. So if you had registered for the session, you should have gotten a one pager with some of these resources. But I just wanted to call some of these out. First of all, we do not have slides and a worksheet available for this session. So make sure to please take some notes, ask some questions. On the positive note, a recording of this session will be made available. This will be found on the WSPA website. And correct me if I'm wrong in the new practitioners page, if I'm correct.
Yeah, and we'll go over that, I think, 2 slides from now, but you'll be able to find that worksheet after we're done with this session and this session is uploaded. The that resource page will be uploaded with the full recording from today.
Excellent. So these are some of the other resources. So Pharmacy Commission laws page. So this is probably a starting point to locate the laws for our state. They do a pretty good job on laying out where the main pharmacy related laws and rules are located. So the study guide we just mentioned will be uploaded on the website. The DEA manual, again, as mentioned earlier, know this super well. If you ever need to look at the MPJE competencies, you can just Google MPJE and look competencies, and they should be able to be right there. The format of today's session, we're going to be following the competencies. So there's going to be at least one question from every single competency area in our presentation today. And then if you want to text, there are a few texts out there. The Facet book, if you just type in Facet Washington Pharmacy Law, pretty much any version after 2020 would be good. So I'd say 2021 up to now is fine, mainly because there was a huge rules rewrite or law update back in 2020. where many of the regulations have updated or changed. So anything past 2020 would be something that you could use. There haven't been that many changes since then that would necessarily be reflected on the MPJE. But if there are any questions, by all means, feel free to let us know. There are also practice questions from other resources as well. My only thing to note is if you are using other resources from other companies, one thing to just watch for is make sure that the items are up to date. And I think I have a slide on that in just a sec. But some resources out there are unfortunately out of date, or some are just plain incorrect. So just want to be very cautious if you're using other resources as well.
And I'll add
And
on to
that's kind
that.
of,
Oh, sorry, go ahead, Jake.
yeah.
I just wanted to also state that with the rule rewrite from 2020, there are some old pharmacy laws, specifically the WACs, that you may be looking up while you're studying for the MPJE. So be very careful that you don't find any of those old WACs.
And just for all of you from out of state, WAC is basically our state's regulations. So that's the Washington State Administrative Code. So most of our pharmacy regulations, not all, but most are found in WAC 246-945. Actually, if you go and look that up, you'll see the vast majority of the pharmacy regulations you would need to know for our state. And again, these are the regulations. For our state, our statutes are the RCWs. But again, if ever in doubt, ask. All right, I'll turn this over to Boris to talk about applying for a Washington State license and WSPA resources.
Yeah, so if you're like me, you're often sitting in the PQAC meetings like the one happening right now, but just I'm here with you all today for this study session. But when you log on to the Washington Board of Pharmacy website, just know that there is an online application now. It is through their Helms system, which just launched April of this year. So when you go on, make sure you are applying everything appropriately, submitting all the right information and things like that. Especially since if you since I know most of you are residents here in this cohort, you probably already either started the application or are waiting for that time to test. So we did upload a resource. You can find it on our new practitioner webpage. So that link is here on this slide. However, in order to access this slide, it is limited by being a member. However, I will note that if you are a recent graduate or you are a resident, even if you're a PGY2, you do get a free year of membership to WSPA. So if you want to access the full guide of how to apply for your license, if you haven't done that yet, create an account, go to the top of our webpage on wsparx.org, click on join, fill out the new practitioner survey. And once we receive that form, give us time to process it. We'll get you an account so that way you can access not only a resource on how to apply for your license, but any other new practitioner resource we published on that webpage.
Excellent. All right. Oh, is there a question? Never mind. If there are any questions, by all means, feel free to put those in the Zoom chat, so we can get to all of your questions. All right. So for today, as mentioned earlier, our goal is to make this a high participation session. So we want everyone to participate if possible. So we are using a polling software called Vivox. It should be pretty simple to use, but this allows people to put in a polling answer. Also allows us to get some feedback on ways we can improve as well. So how do you get onto Vivox? You can just put in your web browser, vivox.app, and it'll allow you to join Vivox. Or you can search Vivox in the App Store and get an app as well. The ID number for today's session is listed over there, 196-275-425. So I'm going to put that in the chat real quick as well. So the VBox app does have functions to ask questions. Please don't submit any questions through the VBox app, just so we have it on the Zoom meeting. So we have one place to have questions. So if you have any questions during the session, please put them on the Zoom chat. All right, so let's go and do a few practice questions just to make sure VBox is working. First one being, how ready are you for the MPJE? Now, if you haven't logged in yet on VBox, the login information is on the top right. So again, our ID number for this session today is going to be 196-275-425. We got a few more moments to log on. All right, let's see what your responses are. All right, so the majority of you are either just starting to study or not feeling so good about that. Some of you are saying have a lot to go. No one feels ready quite yet, so I appreciate that feedback. Yeah, there's a lot of things to study for the MPJE, and we recognize that. And hopefully, we can both be a resource. If you are feeling hopeless, if you need some one-on-one time, I am very happy to work with you to help you study for the MPJE. So again, both of us, Boris and I, are resources, and we want to help you all pass the MPJE. So please, please, please reach out to us if you are feeling hopeless or if you're feeling really lost about the MPJE, so we can help you both. All right, next question. Which topics do you feel the most behind for the MPJE? So there's a lot of choices. We want you to select up to 3 areas here. So those include things like pharmacy personnel, scope and licensing, prescribers and prescriptive authority, facilities and facility requirements, acquisition, storage, distribution, disposal of medications, controlled substances, compounding hazardous drugs, prescriptions, orders, dispensing requirements, record keeping, and miscellaneous topics like HIPAA, regulations, quality assurance. Give you all a few more moments to put in your answers there. Okay, let's take a look here. All right, we have things all over the board today. Excellent. But looks like some common themes look like facilities and requirements. So we'll have a lot of questions related to that today. Controlled substances, which will also have a bunch of questions. Compounding and hazardous drugs, we'll have a few, but those are good questions that will appear on both the MPJ and the NAPLEX. Please reach out if you want to do a little bit more review. I'm happy to review with you all. And then a few other things, prescribers, prescriptive authority, prescriptions, orders, and dispensing requirements, and then a few other topics as well. So I appreciate you all bringing those up to us. And then finally, one more question for all of you. When is your MPJE scheduled? Either you haven't scheduled yet or you're scheduling it soon or later out there. And I realize I don't have an answer choice for like within the next few days or so, but if that's the case, just say July 1st to 15th.
I will also add while you are answering here, when you schedule your MPJ and your NAPLEX, be very mindful of how many days you schedule in between your exams. I've heard a lot of people recommending scheduling them a week apart, just to give yourself some time to rest in between. And I actually agree with that a lot. I can only count on one hand alone people who tried taking it within less than 5 days of each other, myself included. While it is doable, it is not highly recommended. I took my MPJE right about maybe like 2 to 3 days after my Naplex, and it was not a fun experience. I'm pretty sure I also blacked out after my MPJE. But give yourself some time to rest in between. That way you are ready and fully capable of taking whatever exam you're taking next.
100% agree with that as well. All right, let's see. All right, so about half of you have not scheduled yet. That is totally fine. But go ahead, make sure you get your Washington State Pharmacist license application in. Make sure you get your transcripts sent so that you can get that MPJ scheduled. One of the things we notice, especially since there aren't that many testing sites here in our state, the longer you wait, the further out your appointments are for the MPJE. We want to make sure you get those in ASAP sooner if possible, just because that does provide you an opportunity in case you need to take it again. Hopefully not, but in case you need to take it again, it does give you another opportunity to be able to take it again, especially if you're going into residency, knowing how some of the residencies have, I think all the residencies have very strict requirements for when you have to be fully licensed as a pharmacist. So, if possible, get that scheduled as soon as you're able to. All right. Any general questions about MPJE, about general content, or about Washington State pharmacy law before we get started on the session today? Feel free to either type in a chat or unmute yourself and speak up. There's a question on the chat that says, if I have a version of the Facet book that says it's current to September of 2020, is that version outdated? My understanding is that is totally fine. Um, Maybe one thing I would just say is just look on there and just double check to make sure that they are referencing the WAC, was it 246-945 on there? I'm pretty sure that version does reference that. But if it doesn't, then that might be out of date. But my understanding is that version should be current or close enough, essentially. Now, of course, there are updates since July of 2020, but they're more minor compared to that July of 2020 time. All right, other questions. What is the format of the MPJE? So it's very similar to the NAPLEX as well. So it's basically multiple choice. Now, multiple answers, yes, they have questions where you have to select multiple answers. There may potentially be one or two questions where they may have you click on an image, but most of them are going to be multiple choice. I will have to say, from student feedback, there are questions that are like select all that apply. There are questions that are like A, B, C, or all the above. So those questions do exist. They're K-type questions, not the nicest questions. So it can be a challenging exam. A question about, or a note about, out-of-state people complete the NAPLEX first, and NABP will send a NAPLEX score to Washington Pharmacy Board, allow you to schedule for the MPJ exam. Interesting. I am not familiar with that. Um, but okay, maybe you'll have to take the NAPLEX first. Is the MPJ adaptive? Yes, it is also an adaptive exam. So what that means is based off of how well you do on the previous questions, the next question that they select will be of a higher or lower difficulty based off of what you do. That also means the exact number of questions you get right on the exam doesn't exactly correlate with the score, because as you keep getting more and more questions right, they're going to keep selecting more and more difficult questions. So don't let that bother you on the exam. Just keep going and keep going and just make sure you finish within the time limit. Excellent questions. If there are more questions along the way, feel free to put them in the chat anytime. Happy to answer them. And again, just as an overview, again, we're happy to be a resource to all of you. So if you have further questions after the session, by all means, feel free to contact us. So with that, let's go ahead and get started. So I will turn this over to Boris, where we will start with the first competency domain of the MPJE.
All right. Thank you, James. So again, as we go through these questions, feel free to throw in questions into the chat as you've already been doing. Unmute if you have to, and we'll try to answer to our best. But Dr. Lin and I will always go back and double check things and follow up, which is why it is important that if you have not signed up with your contact information on our event page, please do so that way we can make sure we get you any follow-up materials and or items. Let me make sure to put in that link here in the chat one more time. Additionally, I also put into the chat one of the PQAC study guide for the MPJE that was uploaded this last October. So feel free to click on that link, and hopefully that may answer some of your questions that were similar to the ones asked just now. With that, we will move on to our first set of questions for section 1. Next slide, please. Which of these must be completed when a new responsible pharmacy manager is delegated to your pharmacy? Select all that apply. Now, as you are reading these questions, make sure that one, just like the exam, you are rereading the questions, because some of these questions will have things such as select all that apply, accept kind of negative based questions. Additionally, if you see a select all that apply, I've only heard of this happening once, especially on the CPJE. If you're taking that too, be sure to also scroll down on the screen, because sometimes there may be extra answers, and some people have told me that they didn't realize there was a scroll that was on the screen itself. So depending on where you're testing and things like that, the computer system, that may be some things you may encounter. All right, looks like we've hit everybody. Let's see how you all did. All right, very good. So the top 3 answers chosen here are our correct answers. So an RPM, or responsible pharmacy manager, must do a controlled substance inventory. They must be notified of the change in a responsible pharmacy manager, and that responsible pharmacy manager must also do a self-inspection of the pharmacy. So when we think about pharmacies, just to go over the other two answers, a licensing fee must be paid. It's not required. There's no licensing fees for RPMs, and inspections are not done by PQAC. It was years ago, but our rule change has now shifted over where the RPM is now responsible for a self-inspection. Thank you, James. Next slide, please. So I'm just going over some general things you will need to know about RPM. If you're from out of state or you practice in an area where you may see this term in reference as pharmacist in charge or PIC, just know in Washington State, RPM and PIC are the exact same thing. So when the RPM or PIC is changed, they are required to, one, within 30 days, do a controlled substance inventory. Additionally, they must do a self-inspection of the pharmacy using the Board of Pharmacy's self-inspection forms, which can all be found online. And lastly, they must report that change to PQAC within 10 days. So know these as specific facts. I know with the Rite Aid closures and pharmacy closures and things like that, PQAC recently re-emphasized all of these things. So just know not only is it going to be important for you to know for the test, it's also important for you to know in case you run into any of these situations, just as we deal with the current pharmacy closures. All right, I'm not seeing any questions in the chat, so we will now move on to the next question. Which of the following tasks would not be a task that could be done by a pharmacy assistant? So we're really looking at our ancillary utilization, personnel utilization here. So again, as you read through each of these answers, which of these tasks is a task that cannot be done by a pharmacy assistant? All right. So the majority of you did choose compounding an IV bag with multiple ingredients for a patient. Just really quickly, without going over the other four answers, the other four answers here are tasks that can be recognized as a task that can be done without discretion. So specifically, while there's no legal definition in our laws, and PQAC is actually currently going over this, answer number 3, compounding an IV bag with multiple ingredients is a task that requires discretion. Hence why a pharmacy assistant would not be able to do this task. Next slide, please. So our state and our laws are we do have very specific laws when it comes to what pharmacy interns can do, assistants can do, and technicians can do. Aside in reference to what a pharmacist can do. So going over the list on the left-hand side really quickly, things that cannot be delegated to a tech or an assistant is receipt of a transfer of a verbal prescription other than refill authorizations. So note that very specific item right there. So if it's a refill, then a technician technically or an assistant could be taking this, but a verbal prescription in general should be taken by a pharmacist or a pharmacy intern under supervision. Patient consultation is self-explanatory. Technicians, while they have some level of pharmaceutical knowledge, it is not up to the level of a pharmacist or a pharmacy intern. Consultation with the prescriber is also self-explanatory. Interpretation of data in a patient medication record system. Don't confuse this with taking down of data. So if for any reason a technician is, collecting data from a CLIA wave test or a physical exam, as long as they're the ones doing the recording, that is allowed. However, interpreting what those lab values mean is not allowed. Any ultimate responsibility for all aspects of a completed prescription, that one's very specific as like a do not give to any ancillary personnel. So ultimate responsibility for a prescription includes in our WAC, dose, method of administration, dosage form, things like that. Substitution of a medication is not allowed to be done by tech or assistant, especially biological. And lastly, a decision to not dispense is again part of that ultimate responsibility and therefore cannot be delegated to a tech or assistant. Now, because technicians have a license, they are trained in a program, they are allowed some leeway, and that is spelled out by your ancillary utilization plan when that is submitted to PQAC. However, then because assistants don't carry any level of training other than paying a fee for their license to the Board of Pharmacy, note that assistants can only do very much so non-discretionary items. In comparison to a technician and what the state has now allowed over the past several years, on the right-hand side here is a quick list of what a technician can do versus what an assistant cannot do. So pulling a drug, right? Reading the drug name, knowing what the drug is, pulling from the shelf is only limited to a technician. Entering a new order into the system, knowing what PRN means and BID, things like that. Medication administration is very much still new to our state, but is only limited to vaccines when it comes to what technicians can administer to a patient. And that's also assuming that they are trained. So they have a immunization certificate similar to what you all have. We also have a very specific tech law that allows for inpatient single dose units. IV admixtures, right? Technicians can be trained in compounding. MedRec is another training. And then lastly, stocking automated DDDs or ADDs under supervision. So again, just depending on where you're practicing, some of these differ. However, a lot of these items are Washington specific to what techs can do versus what assistants can and cannot do. So know this slide really well. I will also note that while it may not happen during your time taking the test this year, some of this is always changing and ongoing. Even at today's PQAC meeting, they will be discussing whether or not a technician can do what we call a final product verification, kind of like checking bubble packs and things like that. All right, so there's a question here in the chat. Can technicians or assistants prepare oral suspension per manufacturer instructions? So this one's kind of a gray area because our state still sees any handling of a medication similar to compounding. So in terms of mixing something per instructions, that can be seen as compounding and would be something that would be required to be put into the AUP. This could be something that technicians can do, right? Because technicians can receive compounding training. However, I would not, again, this is not legal advice, but I would, in my defense, I would probably not have an assistant do something along those lines. Any other questions? All right, next slide, please. Okay, ON is a pharmacist who renewed their license in 2024 with their next renewal cycle in 2026. How many hours of continuing education would ON need by the time of their next renewal in 2026? All right, very good. So, knowing licensing hours is going to be very important here, especially since you will be asked about both pharmacists and technicians. And also, this question differs by states. Um, so, if you're studying for any other MPJEs or even the CPJE, be very careful about how you answer this specific question. For those who answered number 4, yes, for Washington State specifically, it is 30 hours or 15 every year, but our renewal cycle has now been updated to 2 years versus 1 year. So it used to be 15 per year, but since now we're in a renewal cycle of 2 years, it's 30 hours per cycle, and it's specifically by the birthday of the licensee. Next slide, please. Really quickly though, just know that depending on what state you're going to be in, like let's say if you're studying for the CPJE, it is by the end of the birth month. If you're going to be studying for Idaho, right, they don't have an exam, but like their renewal period is by the end of the year. So it's nothing to even do with birthdays. So just be very careful with depending on where you're going to practice, what exams you're studying for, how that answer is going to differ. Now, in terms of really quickly what each individual licensee needs for their CE, a pharmacist for their licensing needs to take their NAPLEX and MPJE and graduate from an accredited pharmacy school. As we saw from the previous answer question, it's 30 hours per 2 years. One of those hours must be in health equity. We recently passed that law. It took effect this year. So just know if you haven't taken a health equity CE, we loosely define what that is. So just find one and get it done. Additionally, pharmacists do need to take a one-time suicide awareness prevention training. If this question was surrounding technicians, then of course technicians have 2 different exams. There's the PTCB and the EXCPT. At the last PQAC meeting, they updated this to say that there is a new version of the EXCPT, so that's also viable for a technician to get licensed here in Washington State. A technician must also go through a PQAC approved tech training program, whether it's at a community college or at a pharmacy that does its own training program. Unlike pharmacists, technicians do require 20 hours in CE with 1 in health equity and also 1 hour in pharmacy law. So I think we're missing that from the slide, but again, 20 hours, 1 in health equity and 1 in pharmacy law every renewal cycle. Lastly, assistants, no exams, just paying the application fees, what's needed, but they do not need CE hours because they're again doing non-discretionary tasks that don't require continuous training for their license. Now, It should be noted that there is a waiver for first-time applicants if their license was issued within less than the first 24 months after graduating from school. So this may be applying to a lot of you here. Just know by your first licensing renewal period, whenever your birthday is, you may not be required to have 30 hours done. However, if you are close to potentially renewing any of your license at any point, PQAC usually just recommends just continuously do CE throughout the year, so you're suddenly not caught off guard and suddenly you're cramming 30 or 30 CEs into like 1 to 2 months in case you don't have time. So even if you apply and fall under this waiver, just continuously do CEs, go to conferences. There's a bunch of free online CEs to get this done. All right. Otherwise, for other licensing cycles, you may also be asked on like facilities and things like that. So for pharmacy personnel, we can see here it's a 2-year cycle. For facilities, it is a 1-year cycle. So hence, the self-inspection process. And then if your pharmacy does have a DEA license, that is a 3-year cycle. Right. So just addressing any comments here in the chat. If they're taking the Washington MPJ exam, can they take it from an out-of-state location? Yeah. James put in there correctly, yes. So our state specifically has for your NAPLEX and MPJE, it's specifically through Pearson. If you've ever taken the PCAT, it's the exact same company that administers that test. But they do have offices throughout the entire country. There's 5 here in Washington, 1 in Spokane Valley, 1 in Yakima, and 3 over here on the east side where Seattle is. I had just so I can make my licensure deadline, I had to take mine in Las Vegas. So I just flew out to Vegas, took it, and came back and just took my MPJ here back in Washington. Next question here in the chat. Is there a requirement for in-person CE? No. So CE for if you look at what the law states, one thing to think about is there is accredited CE and there's non-accredited CE. It's very rare now to find places that offers non-accredited CE. Most CEs that you get, if it's accredited, will be uploaded to your NABP profile, the same profile that you use to sign up for your NAPLEX and MPJE. And honestly, just so you're not tracking your own CE, you are just take any CE via that is accredited. It doesn't have to be in person, and then the company that accredits it will upload it to your profile. If you do take any non-accredited CEs, then of course be sure to ask for like a certificate of completion, some kind of way to track it. Because if you're ever audited randomly by our board of pharmacy, and they're like, oh, how come you have 29 hours on NABP? You're missing 1 hour. You're like, oh, here's a certificate of 1 hour from this non-accredited CE. So I still have my 30 hours. It is a bit of a pain to track your own non-accredited CE, which is why I usually recommend just take some accredited CE. So that way it's tracked through your NABP profile instead. Right, next question here. A licensed pharmacist from Oregon is applying for a Washington pharmacist license. Which one of these is false about a temporary practice permit in Washington? So one tip I have for questions like this, throughout this session, we'll have a few questions of like which one of these are true or false or accept. When you run into this, it's usually best to make sure that you're understanding what verbiage you're applying to the other answers. So what I did during my exam was I would write 1 through 5 here for all 5 answers. And next to each one, I would put, is this true or false? Because then, again, by reading the question, I'm trying to match which one of these statements are false for the statement, and that is my correct answer. And then anything that said true that I put next to here, that would be the answer I would not choose on the computer screen. All right, very good. So the majority answer here is the correct one. If the pharmacist from Oregon is applying for a Washington pharmacist license, then they may not serve as a RPM or a PIC, again, depending on which term is being used here in the question. Next slide, please. So when it comes to questions like this, looking and understanding exactly the verbiage in the WAC here is going to be important. So the simple way to know how to find the answer is, so if you're on your computer screen, look up this specific WAC and just look at the verbiage. But specifically, a pharmacist transferring from a different state may apply for a temporary practice permit to allow them to temporarily practice while their application is being processed. We don't want to, limit what they are able to do if they are clearly practicing from a different state. This permit may only last up to 180 days and still requires the pharmacist to have their active license from the other state and complete all other application requirements like the MPJE. For licensure in our state, NAPLEX is universal, but our MPJ is not. Therefore, if they still want to have an active license and not just a temporary practice one, applicants coming to Washington still need to pass the Washington MPJE. Any other activities that the pharmacist does based on the previous answers, such as supervising interns and things like that, they can do. However, our law specifically states that they can do anything a regular pharmacist can, except be a responsible pharmacy manager or PIC. Seeing no questions here in the chat. Next question here. Which of the following would not be unprofessional conduct that may warrant additional action by a disciplining authority under the Uniform Disciplinary Act against a licensee? All right, very good. So, depending on those who answered answers 1, 2, 3, remember to reread the question here. Which of the following would not be unprofessional conduct under the Uniform Disciplinary Act against a licensee? So this is specifically anything that would be unprofessional in terms of being and doing things as a pharmacist. Therefore, being sued for a civil dispute involving unpaid rent is not a something that would impact someone's ability to be a pharmacist practicing safely, while these other three can. So, operating under the influence of a substance, including alcohol, maybe a speeding ticket involving, DUI, things like that. Just a regular speeding ticket, not so much. Throw an alcohol in there or a different substance, then yeah, it's going to be now it's under this specific act. Pattern of misuse or unprofessional conduct is a big thing. So we do, we not everybody can be a great pharmacist at times. So if there's unprofessional conduct or if a patient feels like they've been wronged, our state does offer a complaint hotline in case what the pharmacist does or even technician does not fall in line with proper patient care. And then, of course, lastly, as the pharmacist, whether you're the pharmacist in charge or not, you are responsible for ancillary personnel that is working at the same time. So if someone has an expired license, technician or pharmacist or even intern, that does fall under your jurisdiction. Next slide, please. So really simply, we do have a Uniform Disciplinary Act of how pharmacists should be practicing. Again, when PQAC writes these rules and when these are written, it is more so following the idea that can a patient be cared for safely? At the end of the day, most of our RCWs, most of our WACs are written in a way where we want to emphasize and maximize patient safety. You can find the full Uniform Disciplinary Act under RCW 18.130, and it lists a full list, non-exhaustive list, but a full list of things that could be considered as unprofessional and can be disciplined under this specific act. If you haven't read this full list, I highly recommend going over it. It's one of the maybe more interesting laws that won't put you to sleep because of what is considered unprofessional. So that way, if you catch one of those scenarios in a test question, then you can easily recognize it. Right. Seeing no questions here in the chat. Okay, so I think we're on our last question here for section 1. So a licensee was referred to the Washington Recovery Assistance Program for Pharmacy, also known as WRAP, by a coworker. Which of the following would be required of the licensee being referred? All right, so very good. So the majority answer here is, again, indeed the correct answer. So the licensee here, if they were referred to WRAP by a coworker, all they would have to do is fully comply with whatever WRAP requires of that individual. When someone is referred to WRAP, whether it's by work, whether it is by PQAC, whether it's by a coworker, or it's a self-referral, WRAP deals with individuals being referred on a one-on-one basis. So not everybody is dealt with in the same way. It depends. The licensee goes through a full interview with the WRAP employee. And then from there, it is then determined how severe or how lenient, whatever the compliance is. if someone reporting to PQAC is not required for someone because we want to make sure the licensee is going to fully comply with the requirements. This is not something that PQAC requires of licensees, but only if PQAC themselves refer the individual. The second answer is incorrect because there's no reason to report to the workplace unless it is an ongoing issue within the workplace that is a one on very specific incidents. But if a coworker referred to someone, no other party needs to be notified. So that's not something that is required. And lastly, a licensee does not get their license suspended until the program is finished. It is basically left with a loan, just again, depending on what RAP ends up deciding with that licensee. Next slide, please. Oh, very good. So I think the question here in the chat is perfect for the slide right here. So to provide some more context on RAP, when a pharmacist intern, intern or a pharmacist is found to be operating under the influence, using anything like that, that is, while not an uncommon occurrence, it does happen. So if someone who is needs to be referred to RAP, this is for them to recover, figure out why they're using or abusing a substance, whether it's a medication or alcohol or otherwise, so that they can recover and go back to being a pharmacist who can practice appropriately. So individuals who get referred to RAP are ones who, their only issue is potentially using and abusing. And once they are rehabilitated through the program, they are then, depending on their status of rehabilitation, are then allowed to go back into practice. I think most, if not all states have something very similar to something like this. I know for California, because I'm licensed there, they also have something, a similar program. So at the end of the day, RAP is a rehab program for specifically just pharmacists and pharmacy technicians. Other professions have their own version of RAP. This is just what ours is called. Are the exceptions on the WSPA page? Amanda, can you elaborate on what exceptions you're speaking to?
Yeah, sorry. The RAP admission to RAP is generally considered confidential with a few exceptions. Are those exceptions listed on the page?
Not on the WSPA page. So the exceptions are, it depends on what PQAC determines with an individual. So
Okay.
I'm trying to see if I can best answer this question because it's not a black and white answer.
Okay.
The big ones I would say is an individual's admission to RAP is not confidential only if one, there are potentially associated crimes related to why they're being admitted to RAP, which then just depends on what crimes they're being charged with. Another reason would be because if PQAC specifically referred this individual to RAP, it will be because that is done through our board of pharmacy that will show up on public record. Just to show that, PQAC did something about this individual because it was found to be something that went against the Uniform Disciplinary Act in some way, shape, or form, or any of our other WACs and RCWs. And therefore, by documenting the process, shows that this individual was then progressing through RAP and then allowed back into practice depending on their status.
Okay, thank you. So it's like more of a specific case-by-case scenario and probably not something that will be tested on the MPJE.
Yeah. I would say it's hard to find very one-to-one weird scenarios that they'll write into the exams. What they really want you to know, at least for RAP specifically, is that an individual, one, can again self-refer, be referred by a coworker, be referred by work or be referred by PQAC. If PQAC is the one referring the individual, though, know that that is when confidentiality may end up not being applied, because then PQAC has to publicly document that on the licensee's profile, which is all also public record.
Okay, thank you so much.
I see another question here in the chat. Does the crime have to be related to pharmacy? You've heard that someone who's been jailed can still practice as a pharmacy technician. So that just depends more on a workplace. If an individual has been found guilty of a crime related to medications, to practice a pharmacy, the board will then have to determine whether or not they're allowed back into practice, because that again is on a board by board basis from cases that I've seen. But if your crime is, unrelated to pharmacy, then yeah, if you're not going to be a danger to medications, to a patient's safety, and depending on the crime, whether you're jailed or not, right, severity wise, if it doesn't violate any of our Uniform Disciplinary Act or WACs and RCWs, you can still potentially apply as a licensee. All right, so here we will take a quick break. Jane, what do you think? Like 5, 10 minutes at most?
Yeah, let's do a 10-minute break. So let's come back. Was it 10:30, sorry, 10:48 or whichever time zone you're in, 10 minutes from now. We'll get back together in another minute or so. Um, if you've taken my class, you know my tradition. If you haven't stood up yet during this break, stand up, get some fresh air, take a breather. And I mean everyone, stand up. I know today's going to be a relatively long day. We have a lot of sections to go through, so we want to make sure that blood is flowing and the energy is going. Okay, gonna go ahead and get started. So just to address a few quick questions, got a question, direct message from a student about how long this session is going to be today. So officially to about 2 to 2:30 or so, though depending on the discussion, depending on the questions, we may potentially go a little bit longer. As a reminder, this session is going to be recorded. And where it's going to be posted, it's going to be posted on the WSPA New Practitioners website. So if you have any questions past that in terms of how to access, by all means, feel free to let us know. But again, it's going to be on the WSPA website. Thank you, Boris, for posting that link there. And then in terms of a lunch break, so we will have individual breaks in between each session, but we're going to start session 2 in just a moment. And then after session 2, we will have our lunch break. So that's going to be a 30-minute lunch break. And then in between session 3 and 4, we're going to have another 10-minute break as well. Let's see, another question. Are the questions in the session phrased similarly to how the Washington State MPJE exam questions will be? As much as possible. Unfortunately, we don't have access to the actual questions on the MPJE, so we are trying to the best of our ability per feedback from students and from our memories of taking the MPJE ourselves to try and simulate those questions as much as possible. Excellent questions, everyone. All right, so let's go ahead and continue. So now we are going to go into the second round where we're going to focus on the domain related to pharmacist practice. So that includes a lot of different things, including scope of practice, certain dispensing requirements, what are the things? Refills, prescriptions and orders, requirements related to regulations and agencies, returning or reusing drugs, counseling, a whole bunch of different topics. So this is going to be our focus for round 2. So let's start off with a question. You receive a prescription for dextroamphetamine with an ICD-10 code of F03.9, which is unspecified dementia. Upon consulting with the practitioner, they give you a paper from Europe that outlines its use for an off-label condition. You determine from this that this use makes logical sense. What may you do with this prescription? May you A, fill it as is, B, change the directions to an on-label use, but verbally consult the patient or practitioner or caregiver of the off-label use. 3, decline to fill the off-label medication use. So what can you do in this scenario? And if you're coming back, just a reminder, you can log on to Vivox. That is our polling software on vivox.app, either online or through your phone with the ID number 196275425. All right, let's see what you all chose. All right, so the majority of you selected one, and a lot of you selected three. So the correct, the correct answer in this case is three. The pharmacy must decline the fill for the off-label medication use. So why is that the case? Well, in general, off-label uses of medications, yes, we can fill that. But Washington State does have a specific rule regarding Schedule II substance stimulants, where we are not allowed to dispense Schedule IIs for an off-label or Schedule II stimulants for an off-label use. So our state does specify in a list of items that we can use Schedule II stimulants for. And those are listed there like narcolepsy, hyperkinesis, also known as ADD and ADHD, epilepsy, binge eating disorder, and any other FDA-approved use of these medications. So going back to that rule again, in general, for off-label medications, you can dispense and use it for most cases, but it's not allowed for Schedule II stimulants. And then one thing that has recently come up is items under emergency use authorization. So as a reminder, emergency use authorization is the allowance by the government to use a medication that is not FDA approved. But you have to follow their rules specifically to be able to use that. By dispensing a medication for EUA and using it for an off-label use, that is considered misbranding. All right, next question here. With the passing of the MAT Act and the elimination of the X waiver, pharmacists are now starting to get involved in the prescribing of buprenorphine, which is happening in our state. Which of these are correct about the pharmacist's legal ability to prescribe buprenorphine? And I'll get to that question in just a moment there. The answer choices being pharmacists must be under a CDTA signed by a physician with an XDEA number. Pharmacists must use the collaborating prescriber's DEA number. Pharmacists must complete a certification course on substance use disorder. Every prescription written must be co-signed by the collaborating provider, or the pharmacist must have a BCPS or BCACP board certification. So just to address the question in the chat, an off-label use of C2 opioids, is that allowed? It is technically not prohibited. I think that's the better way to put it. With any controlled substance, as a reminder, federal law does require you as the pharmacist to ensure that it is being used for a valid medical reason. So if it's being used off-label, it is your professional judgment to make sure that it is being used in a safe and correct way. So if it is being used off-label, I would recommend more professionally to document that and to document the conversation you've had with the practitioner to ensure that that is correct. But there isn't any specific prohibition saying that you can't use it off-label for C2 opioids. All right, let's see what your answer choices are here. All right, so we got a whole mix over here. So the correct answer in this case is 3. The pharmacist must complete a certification course on substance use disorder. So let's talk about that. So first of all, one of the things that recently happened in 2023 happens throughout all of US was they got rid of the XDEA number. So that is also known as the X waiver or the DATA waived DEA number. So that is gone. So along those lines, number 1 is not a correct answer because the XDEA number is no longer a thing. The next thing has to do with, okay, what is our prescriptive authority as pharmacists in our state? So in Washington State, prescriptive authority mostly follows a collaborative practice. So we have a collaborative drug therapy agreement, also known as collaborative practice agreements in other states. And that is how pharmacists get the ability to prescribe medications. So this collaborative drug therapy agreement is an agreement between a pharmacist and a practitioner, allowing a pharmacist to prescribe medications, and that includes controlled substances. Now, the important thing is, if you are a pharmacist prescribing under a CDTA, you need to have your own DEA number. In addition, what you are prescribing has to be under the scope of practice of that collaborating prescriber's scope of practice as well. But the important thing too is that if you are prescribing under a CDTA in our state, unless the CDTA says otherwise, you will be prescribing it yourself under your name. So it doesn't have to be co-signed, and you do not use the collaborating prescriber's DEA number unless it specifically says in that CDTA that that has to happen. In terms of the certification course on substance use disorder, so that is part of that MAT Act. So the MAT Act eliminated the XDEA number, but one of the requirements they did add to be able to just have a DEA number now is you have to complete a certification course on substance use disorder to be able to get and maintain a DEA number. So kind of mentioned most of that from there. Just want to summarize the slide here. So you have to take the 8-hour substance abuse training. And then a few things about CDTAs, again, written agreement between practitioner and pharmacist, and not a pharmacy, but a pharmacist. In organizations like hospitals and chain pharmacies, you can have multiple pharmacists sign on, but each individual pharmacist has to sign that agreement. It details what a pharmacist can prescribe, at what time, and for what patients. The prescriptions are written by the pharmacist and signed by the pharmacist, not the collaborating practitioner. Again, unless the CDTA specifically says you have to do it a different way. CDTAs are good for 2 years. Any new changes or any changes require a new CDTA. There is a requirement for quality assurance, meaning that you meet or speak with the collaborating practitioner or follow up with them so that we can make sure that that prescribing is good and that it's being reviewed. There is no general requirement for extra training or board certification unless the CDTA specifically asks for that. All right. Moving onwards, now let's talk scope of practice. Which of these healthcare practitioners are not allowed to prescribe buprenorphine for the treatment of substance use disorder? Select all that apply. One point that I forgot to mention with regards to medications, the MPJE and the NAPLEX will not tell you if something is a schedule 2, schedule 3, whatever schedule a medication is. So this is one of those facts that you'll have to know and memorize. In general, when it comes to controlled substances, because the exams are more testing you on applying knowledge, I tend to say the way to study is whether something is a C2, first of all, or maybe the other way I would say is it a controlled substance? And if it is a controlled substance, is it a C2? Because C3 through 5s in general are treated pretty similarly to each other in our state. C2s, on the other hand, are definitely a lot stricter. All right, so in terms of these healthcare practitioners who are not allowed to prescribe buprenorphine for the treatment of substance use disorder. So DO, DPM, FNP, ND, and DDS. All right, let's take a look here. All right, so the majority of you selected DPM, ND, and DDS. So those are the correct answers. So as part of knowing scope of practice, one of the things you would have to know is what do these designations stand for? And what is their scope of practice? What are they allowed to do? What are they allowed to prescribe? So I highly recommend go to the Pharmacy Commission website or just Google who can prescribe and administer prescriptions in Washington State. That'll lead you to our Pharmacy Commission's website. Thank you, Boris, for posting that. A really good resource that basically lists out all the healthcare professions in our state and what they can and cannot prescribe. So just a quick note for our specific practice here. DOs are physicians, mostly unlimited. DPMs are podiatrists, so they can only prescribe for podiatric medicine only. So if we're talking about buprenorphine for substance use disorder, well, technically buprenorphine for pain, yeah, they could potentially prescribe that, but not for substance use disorder. FNP is a designation for a nurse practitioner, specifically a family practice nurse practitioner. So nurse practitioners have many different designations. One thing I would just look for is that NP in their name, because that will help determine whether they are an RN or a NP. So nurse practitioners in our state have mostly unlimited prescriptive authority as long as they are practicing within their specialty. NDs are naturopaths. So naturopaths in our state can prescribe medications. In general, their prescriptive authority is almost all legend drugs, and then only certain controls. So in terms of controls, they can only prescribe codeine and testosterone products only and no C2s. Now, all of this can potentially change because I know naturopaths are working on changing their scope of practice. DDS are dentists, so they can only prescribe for oral health related conditions. So again, back to substance use disorder, not quite for DDS. All right. So you may potentially get prescriptions on your exam or medication orders. So let's take a look at this one here. So you receive this physical prescription. Assuming this is on tamper-proof paper and physically signed by the prescriber, what is your next step? Give you all just another moment to look at it real quick. All right, so moving onwards, what is your next step in this case? Would you, one, fill the prescription as written? Number two, fill the prescription but only for 12 capsules. Three, make the necessary changes without contacting the prescriber. Four, contact the prescriber to take a verbal order. Five, refuse to fill the prescription and return it to the patient. What would you do in this case? So this is one of those application-like questions where you're not necessarily regurgitating a concept, but applying it to a situation. Hopefully you can all see the prescription on the right-hand side. Try to make it fit. Alrighty, give you all a few more moments here. All right, let's see what you all got. Excellent. So let's see. We got the majority of you say fill the prescription as written, and a good amount of you say contact the prescriber to take a verbal order. So what do we do? Well, the correct answer in this case is contact the prescriber to take a verbal order. And in terms of refusing to fill the prescription, generally that's probably not going to be the right answer in most MPJE related questions. But so what's the issue with this prescription? So let's take a look. This is a question related to Washington State prescription requirements. So if we look at this prescription, there's a lot of things that are good about it, but there's certain things that are missing. So in our state, physical written prescriptions in Washington state have a few requirements. Number one, they have to be on tamper-proof paper, and that was stated in the question. The other thing, they need to have two signature lines. So those two signature lines are one that says substitution permitted and one that says dispense as written. So those have to be on a physical prescription. And they also have to have a Washington State seal on them, basically stating that those are approved by the Pharmacy Commission. So because those are missing, this prescription is technically not fillable. Now, this is cephalexin, which is a non-controlled medication. So the other piece would be, okay, so how do we resolve that issue? Being a non-controlled medication, this is something where we can get a verbal prescription from the practitioner. That is one way to solve the issue. Along those lines, any questions I can answer about this? DAW and substitution permitted cannot be flipped either. Yeah, that's correct. So in our state, there's technically an order to those two lines there. So the first line should be substitution permitted and the second dispense as written. What does two signature lines look like? So let me see if I can draw that out real quick. So basically we would have one signature line, not really straight, one signature line here and then one signature line there. This would say like substitution permitted. And then this one would be like dispense is written. I cannot write the letter A, dispense is written. So basically these there'll be two lines like that. And then the practitioner would sign on one of these two lines. So just having that box that says dispense as written is not sufficient enough. Now, I should mention that these requirements don't necessarily apply to prescriptions that originated from out of state. So if a patient brings in a prescription from out of state, they don't have to meet these requirements as long as they meet the requirements of the other state. There's also no requirements for the pharmacy to necessarily contact the practitioner from out of state, including controls, though, again, we have to make sure to do our due diligence to make sure that it is indeed a valid prescription. So what we do to make sure it's a valid prescription is kind of up to us to determine. Alrighty, good questions. Oh, that is stuck on there. Let's see. So while we're on that, let me get the poll started here. So the question is, a nurse calls your pharmacy to verbally authorize a 3-day emergency order for Vicodin for a patient because it is the weekend, and the prescribing practitioner is unable to write a physical or electronic order due to being out of town. How can you handle this situation? So is it 1, fill the order as verbally authorized? 2, fill the order as verbally authorized, but require a physical or electronic replacement within 7 days. 3, get a verbal order from the practitioner themselves and require a physical or electronic replacement within 7 days. Or 4, decline to fill the prescription. All right, let's see what you all chose. Okay, so the majority of you say 3, which is the correct answer in this case. So a few things to know about this question. Number 1 is identifying that Vicodin is a Schedule II controlled substance. So being a Schedule II controlled substance, that leads us to having a different set of rules. So in our state, with regards to verbal Schedule II controlled substances, we pretty much follow the federal laws almost exactly. So with regards to our requirements for Schedule IIs, in general, Schedule II verbal prescriptions are not allowed. But there's one exception, which is for emergency situations. So in terms of emergency situations, as a reminder, this is a situation where the practitioner doesn't have any reasonable ability to give you a physical or electronic order, yet they have a patient who like desperately needs something. So an example that I always use is, say you have a patient who has a severe dental infection over the weekend, but the dental clinic is not open until, say, Monday. So the dentist may potentially verbally authorize a small amount of the medic of C2 for the patient to get them to the appointment. So as a pharmacist, you have to use your discretion to identify A, is it a true emergency? And B, is what they're prescribing reasonable for that time period? And the last and most important thing is, if you do take this verbal order, you have to transcribe it down, and the practitioner has to send a physical or electronic replacement within 7 days to basically replace that order. If that's not done, then that has to be reported to the pharmacy commission. Now, the difference between 2 and 3 in this case specifically have to do with who is allowed to make that authorization. So even if the practitioner tells the nurse and says, hey, can you just let the pharmacy know to authorize that? That is not allowed per federal law. The practitioner themselves has to be the one calling the pharmacy to authorize that. And it's your responsibility as a pharmacist to ensure that it is the practitioner themselves. So these are the points that we just talked about, just summarized here. So practitioner themselves, only for the emergency time period, transcribed by the pharmacist, and then a physical or electronic copy within 7 days. And if it's not completed, the pharmacy commission and the DEA have to be notified. Just a side note, verbal C2 orders cannot be central filled or partially filled. All right, moving forward. A veterinarian wishes to issue a prescription for phenobarbital 15 milligrams PO BID for a canine patient for a year. They're a bit concerned about the owner and would like to limit the prescription to 28 tablets, which is 14 days at a time only. Which of the following would allow the patient to receive the longest therapy while meeting state and federal requirements? So this is a quantity of 28 plus a certain amount of refills. So no refills allowed, 5 refills, 10 refills, 12 refills, and 24 refills. All right, let's take a look. Okay, so the majority of you selected quantity 28 plus 5 refills, and that is the correct answer. Now, why is that the case? So, as a reminder, with regards to the number of refills that are allowed for prescriptions, in our state, we mostly follow federal, although there are a few things that are slightly different, especially in terms of the expiration date. But with Schedule 2s, there are no refills. And to mention, phenobarbital is a Schedule 4 controlled substance. So in our state, we allow up to 5 refills on a controlled substance. So if they prescribed a quantity of 28, they can only add up to 5 refills from there, which doesn't get them very far, unfortunately, not a full year's worth, not 6 months worth, but that is what the legal requirement is. With regards to legend drugs, unlimited refills until expiration. And just note, in our state, prescription expiration dates, all controlled substances are 6 months in our state, and 1 year for legend drugs and OTCs. All right, next question. So we alluded to this a little earlier, but which of these is not true about a pharmacy technician and their ability to administer vaccines? Is it one, the technician must be trained in the task? Number two, that this task must be listed in the ancillary utilization plan. Three, a technician must complete this task under the immediate supervision of a pharmacist. Number four, a trained technician may educate the patient on whether the vaccine may interfere with the patient's oral medications. Five, a technician in training is allowed to participate in the administration of vaccines before they're fully licensed as a technician. To provide some context for all of you who are from out of state, we were mentioning earlier there are pharmacy assistants and then there are pharmacy technicians. So if you want to become a pharmacy technician, you would get your assistant's license and then you can go and uh, start a training program, whether that is through a technician school or whether that is within, say, a chain program. They may have their own technician training programs. So you would be designated as a technician in training at that time while you're on site. Okay, so let's take a look here. Excellent. So number four, the majority selected the trained technician may educate the patient on whether the vaccine may interfere with the patient's oral medications. That over there requires clinical judgment, and that's something that a pharmacist cannot delegate to a technician, regardless of whether the technician knows the information or not. They are not allowed to do that professional consultation. So just a few notes about the others. So technicians must be trained to administer vaccines. So the kind of depends on the ancillary utilization plan, which is the document that says what a technician and or assistant can do in your pharmacy. So it has to be listed on there, and the ancillary utilization plan will say what kind of training must be done. In addition, the any sort of task that is done by a technician has to be done under the immediate supervision of a pharmacist. So immediate supervision is important. What that means is the pharmacist either has to be physically there. Now they don't necessarily have to be in the same room, but they have to be within the same premises and be aware of what is going on and be able to intervene. So that is kind of the idea of immediate supervision. And then a technician in training, while you're in the training program, as long as you're in the training program, you are allowed to participate in the administration before you're fully licensed as a technician. So that is a summary here. And again, as a reminder, pharmacy assistants are not allowed to administer medications. Okay, another question here. Patient comes to your pharmacy. They were just prescribed Depo-Provera, a long-acting injectable contraception. You, the pharmacist, fill the med and prepare to administer it per your protocol. The patient tells your technician that they don't need to speak to the pharmacist about it. How do you, the pharmacist, proceed regarding counseling? Do you A, offer the patient counseling prior to administration? B, do not offer the patient counseling? C, do not offer the patient counseling, but require the patient to get the product at their provider's office. So a key point related to pharmacists administering medication. So it is within the scope of practice of a pharmacist to administer any medication as long as they are trained on how to do that. So that is within our scope of practice. All right, let's see what you've all answered. All right, the majority of you said one, offer the patient counseling prior to administration. Absolutely. So in our states, this is a question about counseling. So our state requires that counseling should be offered to the patient, and that is for all patients, not just Medicaid, like per over 90. And that's for any new prescription or any changes to a prescription. Now, there's an exemption where if the healthcare professional is administering the medication directly to the patient, a pharmacist doesn't have to offer counseling, but the person who is administering the medication would be the one then responsible for educating the patient. So since you, the pharmacist, are administering that Depo-Provera to the patient, you are responsible for educating the patient on it before you administer that medication. And in this case, again, you would also be required to offer counseling because it would be a new prescription for the patient as well. Regardless of whether the patient says they want to or not, you would still have to offer. All right. Moving forward, your pharmacy works with a medication take-back program. Though you don't have a kiosk, you provide empty mail-back packages for patients. As part of this program's requirements, which of these are true? Do you have to obtain an additional DEA credential to be able to participate? Do you have to store completed mail-back packages with medication inside in the pharmacy? Do you have to combine both or are you allowed to combine both controlled and non-controlled medications in a package? Can you charge patients for the use of the mail-back program? And then the fifth is location with a kiosk may not concurrently run a mail-back program. So just some background as you're answering this question. Our state does have a medication take-back program, or more specifically like a medication disposal program that allows patients to dispose of their medications. So when we're mentioning that kiosk, some pharmacies and other healthcare related locations may have the ability to have a specific kiosk. Looks kind of like a mailbox in a way, where patients can discard their medications in there. And those medications do get destroyed from a take-back program. All right, so let's see what your answers are here. All right, so the majority of you selected completed mail-back packages with medication inside must be stored inside the pharmacy. Well, unfortunately, the correct answer in this case is 3. So let us talk about that. So the interesting thing about a medication take-back program is all the medications that are inside or being returned or disposed, they are not the property of the pharmacy. So actually, the pharmacy is not allowed to take possession of mail-back packages with medication inside, because that could also include controlled substances in there. And that would actually be a violation if they store it inside the pharmacy. So these mail-back packages have to be sent directly by the patients back to the facility. And these packages, I'll show you a picture in just a sec, are already pre-labeled with mail-back information. With regards to these packages, if you offer these mail-back packages, patients can put both controlled and non-controlled medications together in the package. There are certain items that are slightly different. For instance, sharps you cannot put in there, obviously. Sharps have to go into a sharps container, which pharmacies can have a sharps container take-back program. And then what was the other class? There's one other class, things that are could potentially be explosive, aka inhalers. Those would have to be in a separate type of packaging, and that's just to ensure that the product doesn't burst, essentially. But otherwise, controlled and non-controlled medications can be within the same package. So the next point with regards to this question is, The kiosk program is different than a mail-back package program. So those are two separate programs. You can technically have both programs at the same time. If you have a kiosk for patients to dispose of medications, you do have to obtain an additional DEA credential to be able to participate in that. Um, on the other hand, if you have a mail-back program, essentially what you're doing is you're offering patients these labeled mail-back packages, and this is given to you by the program. And these packages, you're supposed to give to the patient for free. So you're not supposed to charge them for this packaging, but you also cannot take possessions of the package. And in addition to that, if you have a kiosk, you can also have these envelopes as well. These envelopes make it a little bit easier because you don't have to register with the DEA and you don't need a physical space to hold that kiosk. So it's another way to increase access to medication disposal for patients. And I'm sorry, that was a lot of concepts all together at once. So by all means, feel free to ask me some questions.
I just want to be clear. So when patients are returning medications via like the take back programs, they can put any scheduled drug into those envelopes as long as it's like an approved form, so not like an inhaler in a pill container. But then like when pharmacies are returning medications, that's where it has to be separated by control versus not control.
Yeah, good question. So I should mention those are two separate concepts. So the question was when a patient is returning medications via the medication take back program. Another way to word it is the medication disposal program. Those you don't necessarily have to separate controls and non-controls. That is correct. I should mention there are certain items that are also considered prohibited, though I have witnessed patients using the program for that. So that includes things like Schedule 1 controlled substances. Technically not allowed through the program, but have patients done that before? Yes. In addition to that, certain they actually list vitamins and supplements as one that is prohibited. I think it's just they didn't register that with the program. But again, I have witnessed patients throw away old vitamins and supplements in there as well. So technically not covered under the program, but it happens. So you can basically mix whatever you want in there as long as it's not dangerous. Now, when it comes to the pharmacy, so it's a good point. So when it comes to a pharmacy, if you have medications that you're not using as a pharmacy, you cannot just throw it in the sink, and you also cannot use this medication take back program run by the state. As a pharmacy, you are required to either destroy the medication completely, aka incineration, or number two, use a reverse distributor to send back medications back to the manufacturer or distributor, essentially. So those are the two methods that you as a pharmacy would have to do. Now, if you are doing that, then your controlled substances have to be separated out because there are regulations related to the return of controlled substances back to a reverse distributor. Or if you were to destroy controlled substances, there is a DEA 41 form that you have to use to track anything that you destroy on site. So as a pharmacy, as a business, your requirements are significantly stricter. You can't just toss unused medications into this medication destruction program. So excellent questions. Question, are hazardous drugs allowed to be put into the kiosk? In general, yes. Though, again, if it is a medication that could potentially explode, aka an inhaler, then those are items that cannot be put in the kiosk. I'm trying to think whether the mailback programs have specific hazardous drug related ones or not. Off the top of my head, I can't quite remember. Any thoughts, Boris?
The only thing I can think of is like sometimes the kiosks are handled by a third-party company. So like while the pharmacy may have them on the outside, the pharmacy may not be responsible for whatever goes into the kiosk. One thing that I know I was emphasized on was the pharmacy, if they do go into take the drugs out of the kiosk or like the mail bin or whatever, it's only to just retrieve the medications, especially when the bin is full. However, the pharmacy may not be the one to separate the medications and just follows the protocol set by the third-party company that will come to pick up whatever is inside.
And I know these items are slightly evolving and changing over time. And there are both federal and state related requirements related to this. The state requirements are very similar to the federal requirements, but we have a little bit more openness or more ability to do medication take back because we have our own program. But like Boris is saying, following the company's guidelines, every company is going to be slightly different. Thank you for the resource, Sarah. All right. So yeah, so just a study point with regards to this. So when it comes to disposal of medications, I think it's a good idea to remind yourself what are the legal requirements to dispose of medications, both from the patient side and from the pharmacy side. And I would even venture to say, hey, if you are a healthcare practitioner, say you're a pharmacist in a clinic and you were to dispose medications, what are the requirements as well? I think we might have a question related to that later on, so we'll get back to that if that comes up. But it's a worthwhile study concept. All right, so now let's move on to a federal act. Which of these federal acts was passed to require child safety caps on items that may be dangerous for children? Is it the Durham-Humphrey Amendments? Is it the Poison Prevention Packaging Act? Is it the Federal Anti-Tampering Act, the Caustic Poison Act, or the Drug Quality and Security Act? Give you all just a few more moments. I should say quite a few of these acts have a Washington State similar act as well, which almost follow exactly what the federal act says as well. All right, let's see what you all answered. Okay, Poison Prevention Packaging Act, and that is correct. So just a quick note about what these different acts are. So the Poison Prevention Packaging Act is the one that has to do with making sure certain products are safe from children, aka sets the guidelines for the child-resistant containers. I highly recommend study which medications are required to be in a child-resistant container and which ones are not. Our state pretty much follows the federal laws regarding that. So I would recommend just look at the federal laws. The other acts, Durham-Humphrey amendments, define which products require a prescription to be distributed. Anti-Tampering Act, this is the one that created the tamper evidence seal on your OTC products to identify if it's been tampered with. Caustic Poison Act, so this defines caustic poisons and what you're allowed to do with regards to selling those. To be a little more specific, caustic poisons are like the chemicals, so like hydrochloric acid, sulfuric acid. There are specific labeling and packaging and selling requirements related to those. There's also another poison act. I just call it the poison poisons, which include things like arsenic. And there's also specific rules related to how you're allowed to sell those as well. The Drug Quality and Security Act. This is the big one, the latest and greatest. So you probably heard of the DSCSA, so the Drug Supply Chain Security Act. This has to do with identifying and preventing counterfeit products from entering our supply chain, and also being able to track products step by step through our supply chain. The Drug Quality and Security Act also includes the Compounding Quality Act, which also basically modernized and defined a lot more things with relation to pharmacy compounding. A note about our state. Our pharmacies, our state follows the compounding rules, the federal compounding rules, pretty much almost exactly. All right. Next question. Which of these would be considered a system level intervention to help prevent medication errors in a facility? Should you enact a 3 strikes policy to discipline staff who continuously make errors? Should you encourage a staff member to work on one item at a time instead of multiple items at a time? Should you enforce that errors are only reported internally to prevent HIPAA incidents? Should you perform root cause analyses on all safety events, even if a duplicate situation occurs? Or should you require similar looking medications bottle be placed next to each other so staff members can concentrate on picking the right one? So which of these would be a system level intervention? So this kind of a question is one related to quality assurance, and it is one that you can potentially see both on the NAPLEX and the MPJE. All right, let's see what you all chose. All right, number 4, performing a root cause analysis on all safety events, even if a duplicate situation occurs. Yes, indeed, that is the correct answer. So what about the others? So A, enacting a 3 strikes policy, that's not good practice there. The move right now in quality assurance is to move to really, rather than punishing a person for an error, really working on looking at system level interventions and working with people to not discipline them, but to work with them to help them learn and decrease errors. Encouraging a staff member to work on one item at a time instead of multiple items at a time, that is a great intervention. It's not necessarily a system level intervention, it's an individual level intervention rather than a system level. So that's why 2 would not be correct. 3, enforcing that errors are only reported internally. Again, this is one of those concepts where we're moving towards trying to make sure that errors are reported not just internally, but on a grander scale, to help us as a community learn more about medication errors. Now, of course, you would have to report that information de-identified as much as possible to prevent HIPAA incidents. And then number 5 is a bad idea. You don't want to place similar items next to each other. That will just make it very easy for someone to pick the wrong one. So that is what we have in terms of the answer choices here. So yeah, I would recommend studying a little bit on quality assurance and medication safety, both for the NAPLEX and MPJE. And there are different categories to kind of look at. Things related to current topics, things related to, say, Swiss cheese model, to interventions, and to some of the general concepts of what you may see in a pharmacy setting and how to prevent errors. All right, moving onwards. So you see a patient in an ambulatory care clinic for a patient's diabetes management, and you have updated their dose of insulin. To which of these entities or persons may you disclose necessary information without the patient's written consent? Select all that apply. So can you disclose to the patient's primary care physician? Can you disclose to the patient's spouse? Can you disclose to the patient's insurance company to bill for the service? What about their dentist? What about your coworker who saw the patient once last year? Who of these are you allowed to report this information to? All right, let's see what we all got here. All right, so perfect. The majority of you selected primary care physician and insurance company. Spouse and dentist, okay, those are some thoughts. Now, they don't necessarily have access. Remember, when it comes to disclosing information, there are the laws related to HIPAA, and also we have Washington state privacy laws as well. In general, they follow each other very similarly. Our state's privacy laws have additional items related to, say, minors and what a minor is allowed to consent to, and what information they are allowed to hold. In addition, items related to mental health and related to HIV, as well, are items that have slightly different rules related to HIPAA in our state, that is. So going back to patient privacy laws, so PHI can only be shared without the patient's consent for treatment, payment, and healthcare operations. So is that dentist specifically has a need to know about the change in insulin dose? I doubt it, because the dentist is not necessarily um, managing the patient's insulin. Now, of course, knowing that the patient has diabetes is important, but we don't necessarily need to let them know that their insulin dose has changed. Now, the patient's spouse, they don't automatically have access. Technically, the patient would have to give consent for their spouse to have that information. Now, in our state, um, if the facility can reasonably show that the patient does not object, such as the patient comes into the visit with their spouse, then that is allowed. So we have a little bit of judgment to decide, hey, if they're coming in together, maybe that means the patient is consenting to their spouse having that information as well. But it doesn't hurt, say, if you are discussing a very sensitive topic, to ask the patients whether they would prefer their spouse to be in the same room as them or not. All right. So pharmacy practice had a lot of different concepts. Before we go on lunch, what questions can I answer? Right. So just as a preview for session 3 and 4, session 3 is going to focus on dispensing requirements, and session 4 on pharmacy operations. But with that, let's go ahead and take a lunch break. We'll do a 30-minute lunch break. If you need to take just a little bit longer, that's totally fine. Get fed, get some energy, get up, and have a good lunchtime. So we will see you all in 30 minutes. In terms of our time here, that would be 12:15. Okay, well, let's get started, everyone. Hopefully, you all had an opportunity to grab a bite to eat and grab a breath of fresh air. We're going to be continuing our session now. So we'll have sessions 3 and 4, and then we will be done for the day. So let me turn it over to Boris for round 3.
All right, thank you, James. So let's just get things rolling. Next slide, please. All right. If you haven't, if you need to log back onto VBox again, the instructions are in the upper right corner, so that way you can join in and participate. So let's go with run through the questions and let's get this rolling. A physician submits an electronic prescription for themselves for oseltamivir 75 milligram tablet to dispense 3 boxes with directions written as use as directed. When you call to confirm, the prescriber says they are trying to get some boxes ahead of time to distribute if H5N1 bird flu becomes serious. How should you as a pharmacist respond to this? Should you dispense after updating the directions? Dispense only 1 box? Have the practitioner submit a prescription under the facility name? Have a different practitioner submit the prescription? Or decline to fill this order? All right. So it looks like the majority answer here is decline to fill this order, and that is correct. So with the other 4 incorrect answers, let's go to the next slide to explain why E is the correct answer. So just to go over, when a prescription is written, the prescription must be issued for a specific patient for a legitimate medical purpose in due course of practice. So in the previous question, the physician wrote it for themselves. However, it was 3 boxes and the direction was use as directed. So right off the bat, right there, use as directed, it while can be written for some prescriptions, generally is frowned upon. Additionally, we as the pharmacists made the call to the physician and said, hey, what are you using this for? And they're like, oh, just preemptively using it in case the bird flu gets serious. So in this case, it's not for a specific patient. There's no legitimate diagnosed medical purpose. You can't just give something out just because you're preparing for something. And of course, in due course of practice, if there's no confirmed case and no evidence that someone is actually sick with the bird flu, then again, there's no legitimate reason to write that prescription. Now, there is always some question on whether or not a physician can write a prescription for themselves. Usually this is technically allowed, but it is frowned upon. For the most part, when you get a prescription coming in, you want to make sure it is written by someone who has a clear, what we call a clear provider-patient relationship. So while this doesn't have to occur in the medical setting, as long as someone can provide a legitimate medical purpose, they've seen the patient, they've done what you trained as a pharmacist believe is all the right diagnoses, tests, things like that, then, you know, at that time, then if the patient does need a prescription, then the provider can, in that moment, issue some kind of prescription. Of note, a practitioner can also get the medication themselves. However, they are limited by a 5% rule, so we can't while they can get a medication for themselves by a wholesaler, they can also purchase one from a pharmacy. But the pharmacy also has to remember that they are not a wholesaler and their sales out cannot exceed 5% of their total revenue. Sorry, so for the next few sections, there might be a lot of talking from us. If at any point we need to stop or you need to pause for a question, also please let us know. All right. Next question. A patient just moved to Washington and wants to get their levothyroxine transferred from California. Assuming that this prescription is from an ARNP, they filled it before, and it's not an emergency situation. Which of the following are valid methods of transferring this order over? Verbal electronic fax, just electronic fax, just verbal and fax, any of these three individually, or this product cannot be transferred. All right. So this one is a bit tricky, and the only good way of going over this is to show you all the next slide. So in this case, the correct answer here was just electronic and fax, so not verbal, electronic, and fax. So we go to the next slide. This is where reading the specific law and knowing the situation is going to be very important as part of your studying, because again, you may think something is like, you can totally take it as verbal, but our specific Washington state law says otherwise. So if you look at if you go to the specific WAC here, 246-945, 345, in that specific WAC, if it's a legend drug, and in this case levothyroxine, then it's fax and electronic only. The only exception for the verbal is if it's an emergency. But we stated in the previous question, it was not an emergency. Therefore, transfer refills for legend drugs in Washington is fax and electronic only. So given the change in e-prescribing nationally, a lot of this is good to read upon what has changed or what's the newest rule or regulation in regards to e-scripts. So without going over this too much, because there is a lot of information here, if you want to write this down as a quick note, as just write down the WAC as well as the CFR here, because knowing both of those, given the most recent changes, will help you in studying for what happens if you run into a similar question where you're provided a scenario and you need to choose the correct answer here. All right, just addressing some of the questions in the chat. Thank you, James. Pharmacies can dispense for prescriber's office, but sales should not exceed 5% of revenue. Yes. So when it comes to pharmacies, remember that a pharmacy as an entity, at least in Washington, can register as a pharmacy that dispenses or a wholesaler / manufacturer. So if you want to be, just selling drugs without a prescription, right, then you're wanting to register as a manufacturer or wholesaler. But for the most part, these questions are going to be surrounding the fact that what if it is a pharmacy, right, specifically, and they are wanting to sell their medications. A pharmacy cannot exceed that 5% of the revenue. in order to not then have to also register as a separate manufacturer slash wholesaler entity itself. Next question in the chat, this would apply for transferring prescriptions from any state to Washington, not the other way around. Yeah. So this is just from outside transferring to Washington. Other states will have their own rules in regards to this, but for us, just specifically just refer to 246-945-345 for what Washington wants in terms of any of these situations. All right, seeing no other questions. Next question. A small hospital does not have 24-hour pharmacy services, nor does it have remote order verification. They keep some prepackaged medications in a few automated drug dispensing devices. If the hospital staff needs to retrieve medication from one of these devices for overnight non-emergency use, does a pharmacist need to review the order before the medication is retrieved? So again, read very carefully if you when you encounter these types of questions, know what your scenario is. This is a hospital, so inpatient setting. Medication is inside the ADD. Hospital staff is wanting to retrieve it overnight, right? Usually when you have less staffing. What is the pharmacy/pharmacist's obligations to reviewing that retrieval? So one, the RPH must review the order before any medication is retrieved. The RPH must review the order within 24 hours, 6 hours, 1 hour, or no, overnight orders are exempt if the hospital does not have 24-hour pharmacy services. All right, so the correct answer here is indeed the majority answer. So the pharmacist may review the order within 6 hours of the pharmacy opening. So let's look at why this is the case on the next slide. So here we're just going over specifically drug utilization reviews. In general, before any medication is dispensed or given, there should always be some kind of DUR. There are exceptions, and one of them being our scenario question that we just had. So if you are a system or hospital system, your pharmacy doesn't have 24-hour pharmacy services, which honestly is a much more commonly occurring thing, just given just pharmacy things happening. In this case, if the medication is something that doesn't require like some kind of protocol associated with it and is can be given, right, administered, it's in the hospital inpatient setting too, then of course you can set up a policy and procedure to allow for retrieval of a medication from the ADD. However, in this case, because there were no 24-hour pharmacy services, specifically in the WAC, the DUR must be done within 6 hours of opening of the pharmacy. So one other way that this question could be presented is as a time question. So if the question was written in a way where, same scenario, but the pharmacy doesn't open until, let's say, 9 a.m., your answers could be presented as, pharmacists must review the order by, what is it? If it opens at 9, so 6 hours is 3 p.m. So 3 p.m. on that day, AM or PM, depending on how specific they want to get. So that could be a way that that question could be written. But again, just knowing what the exceptions are here and know what the requirements are for that DUR is going to be very important. All right, which of these facilities or dispensing cases are considered exempt from having to report to the Washington Prescription Drug Monitoring Program? You may know this as the Washington PMP. I know if you're coming out from another state, it might become as a different acronym. This is just the online system where you have to report dispensing data, usually around controlled substances, but that's not always the case, but we'll go over that. But for now, each of these scenarios is, again, which one is exempt from being reported to the Washington PMP? So a vet dispensing Ultram, a pharmacy dispensing phenobarbital, a physician dispensing Lyrica, a pharmacy that's not dispense any controlled substances, and a physician administers a single dose of oxy in clinic to their patient. All right, very good. So the correct answer here is indeed a physician administers a single dose of oxycodone in clinic to a patient. Now, when James and I were reviewing this question, we actually got tripped up by this question as well. Initially, we thought that 4 would have also been correct, but it depends on how you read and interpret the WAC. So let's go over the next slide. What the PMP is and what the reporting requirements are. So you can find the reporting requirements and exemptions in RCW 7.225. So in terms of reporting to the PMP, all dispensing of controlled substances from schedules 2 to 5 must be reported to the PMP within 1 business day, regardless of who is dispensing it, except vets. Vets may report quarterly. Now, when it comes to reporting medications to the PMP, though, just know that the PMP is not reporting of just controlled substances, though. Technically, you can report any medication to the PMP, especially those with abuse risk. So as an example, you could even potentially report gabapentin, right? Gabapentin is a legend drug. However, we know there is a potential of abuse with it. So if you really wanted to, you could report any dispensing of gabapentin. If you have any inclination that there is abuse going on, but know that there is a requirement, though, for any scheduled substances. Of those other exemptions that we mentioned, you do not have to report, though, if you do not if you're dispensing for a less than a 24-hour supply. If it's a dose that's being administered directly to the patient, such as our answer in the previous question, or it's a Department of Correction medication where it is being directly, in this case, still being directly administered to the patient in that healthcare setting. For those who did choose C, right, I think was the other answer, just know that in the RCW, you still have to report to the PMP that you didn't do any dispensing of controlled substances every 7 days. And that is directly written in the RCW. All right, don't see any questions here in the chat. So in terms of, well, don't remember if we had something specific for this slide, James. But I think it was in regards to knowing when it comes to prescriptions and whether it's partial fills, full fills, just know that these are some areas that you may be tested on, and we do actually have specific WACs and RCWs on this. Just as an example, one WAC I know that is generally asked upon, especially during like wildfires and stuff, is anything regarding government declared emergencies. We do have a specific WAC on that. If we do have a question, we'll go over it, but just know that that is one specific WAC that does get asked every once in a while on the exam. All right, so next question here. Your community pharmacy receives a prescription today from a long-term care facility for generic MS Cotton for a quantity of 120 tablets. The facility will like you to start with dispensing 20 tablets, but may decide to request more tablets in the near future. How much time does the facility have to receive the remainder of the tablets before the prescription is voided? So do you need to dispense everything immediately and then anything not filled is voided? Or do you have time to fill the remaining within 72 hours, 30 days, 60 days, or 180 days? All right. So it looks like a majority of you chose 30 days. So one thing about, excuse me, one thing about Washington pharmacy law is that you have to be really careful, especially about what healthcare setting you're in. And that changes whether or not you can dispense like remaining fills or partial fills to a patient. So the correct answer here is actually 60 days because specifically it is for a long-term care facility. So let's go over really quickly of what kind of nuances we have to be able to know when it comes to the healthcare setting and who gets what kind of special rules. I will say for Washington, we do have a lot of very specific laws about long-term care pharmacy where they have a lot of like exceptions and things like that, especially when it comes to like electronic prescriptions. So be sure to know what the exceptions are when it comes to long-term care. So in our question, generic MS Cotton is a C2 med. So with C2s, there are, especially with partial filling, there are 3 scenarios we have to consider. So the first scenario is if the pharmacy is unable to fully supply it because they don't have the stock, then the correct answer would have been 72 hours. If it was a partial fill because it was specifically requested by a patient or prescriber, then the remainder has a 30-day from the issue date in order to fill the remaining quantity. And of course, again, Washington has very specific weird laws about long-term care and hospice. So if it was because our question said long-term care facility, it is a 60-day from the issue date if a partial fill was given out. So again, there's one of those weird scenarios where definitely double check what healthcare setting you are in before you choose to answer the question. Okay. A label of a compounded IV and ceph bag for an inpatient must legally contain which of the following at minimum, except? So with the way this question is written, again, the moment you run into any questions that are which one is true, which one is false, which one of these are except, make sure you know exactly what you're trying to identify. All right. So the majority answer was internal identification number. However, the correct answer here was patient name. So may feel weird about it, but again, it comes down to our specific state law and specifically also USP requirements. So let's go to the next slide here. In terms of medication labeling, especially for a IV compounded medication, there's a really short WAC. If you want to look it up right now, it's 246945017. It clearly just states these very simple requirements where it needs to at least have the drug name and the drug strength when it is compounded. However, then the rest of it, we in Washington, we defer to just USP 795, 797, 800, and 825 in our state rules. So then, because we have to follow whatever is in USP 797, 797 lists all of those other requirements, which in this case does include that internal identification number, that beyond use state, strength or concentration, and route of administration. All right. Which of these statements is correct regarding child-resistant containers for dispensing legend drugs? So a physician may require all medications for a given patient to be provided in a non-child resistant container. A patient may authorize medications to be dispensed in a non-child resistant container, and authorization then is documented. A pharmacy may reuse a child resistant container, assuming it's verified to be clean, unbroken, and in working order. And lastly, a pharmacist may dispense non-child resistant containers to a patient without the patient's consent if the pharmacist deems it medically necessary. So in this case, which of these statements is correct, or which of these statements is true? And so we want to look for that true statement. Awesome. Okay, so the majority answer here is indeed the correct answer. So let's go over each of these answers together on the next slide and why B is correct. So in terms of child-resistant containers, we do have a WAC for it. You can find that in 246945032. But when it comes to child-resistant containers, answer A is not correct. Physicians can authorize per prescription they prescribe for dispensing, but not require for all medications for a given patient. So this is one of the big nuances that you have to remember is, so a physician can technically request for this, but it's on a prescription by prescription basis. A physician cannot ask for a blanket waiver of medications for a patient. B was the correct answer. The patient does have the authority to authorize. It should be documented, but what you document is not specified, is up to you in the system. But a patient does have the authority to request a blanket authorization for the medications to be dispensed in child-resistant containers. C is not correct. You should never reuse a container in general. Is never, just again, from a patient safety standpoint, the safest answer here would probably not to be choose C, because there's no way you can truly confirm what the condition of that medication was, anything that was previously in it, how it was stored, et cetera, et cetera. Lastly, D is not correct. A pharmacist may not designate themselves as the patient's agent. And of course, you can't do it without the patient's authorization. Now, as a pharmacist, you can talk to your patient about allowing for child-resistant containers. However, that then is up to the patient to then determine what kind of non-resistant container they want to have, what medication it applies to. Again, the full authority is still passed from the patient over to you as the pharmacist. All right. So the FDA initiates a recall of a batch of cetirizine. The packaging has a misprint with an expiration date 10 years too far out. They don't think this would cause the patients any harm. So which class of recall would this fall under? Is it a class 1 recall, class 2, class 3, class 4, or this is not considered a recall? All right, pretty good. So the majority of you did choose class 3 recall, which is great. That is the correct answer. So when it comes to recalls, the best thing to just know is the general definition. So if there's ever any misbranding or contamination, right, of a medication that warrants a recall, it should happen. In the case of our example here, it would be a mislabeling, right? However, that doesn't mean there's any contamination, but it requires a recall. Because it's not going to cause any major adverse health consequences, right? There's nothing wrong with the medication. It's just the labeling that was wrong. In this case, it can't be considered a class 3 recall. And by the official DEA and FDA guidance definition, there are 3 specific levels of recall. A class 1 recall is where there is something wrong with the medication. Maybe the drug or device has been exposed to something, broken, but whatever the cause may be that's affecting the drug or device, using it or ingesting it will cause very serious health consequences or death. And so a class 2 recall, though, is if there's something happening to the drug or device, but it may cause some medically reversible adverse health consequences, where serious adverse consequences is remote or may not be too serious. When in studying for recalls, especially the definitions, even after taking 2 different state law exams, I will let you know right now, they're not going to try to make this question too tricky. However, at least the pattern I've seen for this question is class 1 recall is this patient is going to die if they get exposed to this drug or use this device. Class 2 is they're going to have some either serious adverse reactions or some major issue that they could potentially recover from. Whereas class 3 is there is not a lot of harm that can occur. That's kind of what I've boiled it down to when I've encountered these questions on the exams. So there is no true like black and white way of like these situations will warrant class 1, class 2, class 3. So using your best judgment when you study these 3 different definitions, just which one of these 3 definitions apply best to the scenario at hand. James, I don't know if you have any other advice for this, but that's usually how I've gone about it when it comes to recalls or even receiving the FDA emails and just seeing what they classify it as.
No, I agree with you 100% on what you mentioned.
Okay, next question. So if a registered nurse is to administer acetaminophen 500 milligrams to a patient in a long-term care setting, which one of these must be true about the product? 1, the medication must be labeled with a minimum of medication name, strength, and expiration date. The medication can be administered without an order because it's an OTC medication. If a patient owns their own acetaminophen, their product can be administered by the RN instead of the item being dispensed by the pharmacy. The medication must be dispensed by a long-term care pharmacy only, or all of the above are true. All right, very good. So the majority answer here is indeed the correct answer. So the medication must be labeled with a minimum of a medication name, strength, and expiration date. So let's go over into the next slide. So if you haven't noticed, another question about long-term care. And we again have very specific rules when it comes to long-term care in Washington. So with this specific question, the WAC that dictates the requirements are listed in 246.945, 018, and it has the minimum elements that must be in any prepackaged unit dose medications dispensed to any facility. So you can read those requirements in the WAC itself, but just going over the other answers of why they are incorrect. So any medication that is administered by a healthcare worker does require a medication order regardless of OTC status or otherwise. And again, this applies to the long-term care setting. Know that this does not apply to adult family homes as there are no laws regulating adult family homes at the moment. So, but for the most part, you will be receiving questions more so along the lines of what is written and regulated, which is long-term care pharmacy. Also, additionally, any medications administered to a patient in a long-term care facility must have some kind of chart order associated with it. Even if the patient brings in their own medication, any medication dispensed or administered by any healthcare worker, including a pharmacist, should follow a medication script or chart order in the facility. Lastly, the medication does not need to be dispensed by a long-term care pharmacy only. Any regular pharmacy can have long-term care pharmacy services, but just know that if the pharmacy serves a patient in a long-term care facility, they do have to follow all the rules and regulations that are written into Washington state laws. So oftentimes you do have pharmacies here in Washington that operate, maybe one side is a community pharmacy, and they have to follow their own laws, but then the other half of the pharmacy is a long-term care dispensing pharmacy. So medications between both sides cannot mix, and then what medications come out of either side going to the specific patient must be regulated by its associated laws. All right. You are looking to create your own line of private label OTC products for your independent pharmacy. Which of these is correct regarding how you will need to label your OTC packages? 1, the label for acetaminophen must include a warning for Reye's syndrome. 2, the label for esomeprazole must contain the phrase, "Caution, federal law prohibits the transfer of this drug to any person other than the patient for whom it was prescribed." 3, the label for saw palmetto must include the indication for use for the treatment of urinary symptoms. 4, the label for cetirizine must list all active and inactive ingredients. Or 5, all of these are correct and required. All right, very good. So the majority answer here is indeed correct. So when it comes to OTC packaging and the requirements and the labels, hopefully you all remember what the labeling requirements for OTC products follows its own rules, as well as prescription products also follow its own rules. So really quickly, as a pop quiz, can anybody type into the chat what would actually make number 1 true? What's the correct medication here when it comes to Reye's syndrome? Yay. So aspirin is what is more associated with Reye's syndrome, especially with those under the age of 18. So that one would be required. So number 2 is more so because we're talking about OTC products, it's actually more so for a prescription label, right? A written prescribed medication is what is prohibited from being transferred to any other person other than the patient or the ultimate user. Number 3, remember that it's not the FDA, but more so the FTC states that in terms of mislabeling of a medication, we cannot include any treatment proposals, right? OTC, especially with vitamins, minerals, and things like that. They are not allowed to state that it's for the treatment of something unless it is actually for an FDA approved medication, right? So saw palmetto is nothing more than a losing the word here. It's
Supplements
vitamins.
or
Supplement, yes. I'm like, it's the S word. Thank you so much. It's a supplement, but because it has not been shown and proven for the treatment of anything, therefore the labeling does not, you cannot label it as the treatment for a disease state. For cetirizine, of course, for OTC labeling, you have to follow all the general rules when it comes to just labeling any medication with both the active ingredient, the inactive ingredient. On screen, you can see here, if you picked up any OTC medication, these are all the items that are required to be listed. And then lastly, oh yeah, of course, because we have already identified 3 wrong answers, 5 was it, the last answer was incorrect. It can't all be correct. Just additionally, as some reminders, so some medications or drug products do require additional warning. Acetaminophen with the liver warning because of the hepatotoxicity, NSAIDs, stomach bleed warning, aspirin and salicylate, just like you've all identified, is the Reye syndrome. And then contraceptives does not protect against HIV and STDs. With the supplement regulations, again, this is more of an FTC thing, but you can't claim to treat or diagnose, or prevent a disease. And lastly, the legend drugs, the reasons why we have RX only is because of that federal law preventing the transfer of it to anybody other than the patient. Okay, which of these is exempt from being in a child-resistant container? Is it loperamide, acetaminophen, lisinopril, ferrous gluconate, or vitamin C? Very good. So the majority answer here, vitamin C, is indeed the correct answer. Now, remember, this question and the reason why we bring this up is, again, from a patient safety standpoint. So when it comes to child-resistant containers, because of previous incidences that's happened historically and when this law was passed, the rules and regulations surrounding child-resistant container is actually more of a federal law thing. So if we go to the next slide, it's a bit much. So there are certain OTC items that are not exempt from child-resistant containers, and that's just the ones we have listed here. So you can see the idea is if a child or someone who doesn't know better were to have access to any of these medications and potentially have easier access to it, and then ingests it or somehow gets it into their body, will it cause some kind of harm to the patient? So we can see in terms of some OTC items, acetaminophen, again, the hepatotoxicity, NSAIDs, the bleeding risk, the diphenhydramine, some of your iron supplements. These all are OTC items that may need some kind of child-resistant container. In terms of prescription items, a lot of more or less the idea is a lot of your prescription items are going to need a child-resistant container, right? Again, toxicity is a thing. There are some exemptions, and I know some of these are more easily recognizable. So the easiest one always is nitroglycerin, right? You don't want someone in case of an emergency having a hard time getting into their nitroglycerin. Let's just not have that happen at all. Other exemptions do include any creams, right? So something that is not going to be made specifically to look like candy and to be ingested as such. Other things may also include oral contraceptives. Again, because some of it is used as an emergency, such as Plan B, we don't want to have that as an issue. But if you truly want the full list, I don't know if it's on this slide or the next slide. But if you really want the full list, it is, let me put that here in the chat. You can read it on your own. It's actually a fairly long list. It's a CFR. So again, it's a federal law. They are very particular with what drugs need to have what. And my general advice for studying for this, if you are worried, is to have recognizable items identified, what OTC items are exempt or what prescription items are exempt. Okay, a fun one. Which of these items may you sell to a 16-year-old patient without a prescription in Washington State? Primatene, guaifenesin with codeine, Delsum, Nicoderm, or Narcan? Very good. So the correct answer here is indeed the majority answer, which is Narcan nasal spray. So let's go over the next slide why each of these answers is correct or incorrect. So here in, at least in Washington, especially with now with naloxone as an OTC item, you can't actually sell it without any restriction. Additionally, when you think about it, you probably don't want to restrict selling Narcan to someone who may potentially need it. However, going over the other answers, so A is incorrect. So primatene is basically ephedrine. And we have a very, very specific RCW when it comes to anything related to Sudafed, ephedrine, anything basically used to make methamphetamines. So we do have a limit for those who are 18 years of age or older, and a documentation requirement as well when it comes to selling anything that is a ephedrine or ephedra similar item. And if anything, it was just maybe, I think, 2 years ago where just improper documentation of a pharmacy not documenting appropriately who they were selling just Sudafed to resulted in, I think, like a $500 fine to the pharmacy. They settled with the state board. So not only is there a age limit, but there is a documentation requirement. B is incorrect because codeine is a controlled substance. Even though this medication can be sold OTC, there is still a law requirement of the 18 years of age or older. Really quickly addressing the question in the chat. So the primatene and all ephedrine products need to be behind the counter at the pharmacy. So there is no specific law saying it needs to be behind the pharmacy, behind the counter. It's just that because of it requiring the documentation purpose and everything, that pharmacies choose to dispense it and have it behind the counter. So this is one of those things where like practice is a little bit different than the law itself. So again, there's no wording specifically for like, oh, because of this, it needs to be behind the counter, but just know that there's an age limit and there's a documentation requirement. So therefore, company or pharmacy policy then is changed so that it is sold behind the counter so that the pharmacy follows those laws. Let's see here. C is incorrect. Delsum is dextromethorphan. It is an OTC product, but dextromethorphan is restricted to 18 years of age or older. Don't know if anybody here is familiar with the term robo-tripping, but it is an easily abused medication that is also used for getting high. And then lastly, D is incorrect. Nicoderm is, of course, your dermal nicotine product. Just like any tobacco products, we do have an age restriction of 18 years of age or older. Other than that, the only final, let's say, pop quiz question I have here for you all is true or false, pharmacists in Washington State can prescribe Narcan. Very good. So I'm seeing a lot of trues come in. Narcan is one of the few products here in Washington State where, unlike the CDTAs that are required for prescribing of other medications, Narcan currently under Washington State is a standing order medication. So it is a standing order by the state that pharmacist is allowed to prescribe and dispense Narcan. So therefore a CDTA isn't required. So that's just one thing specific to our state that you may need to know. Don't know what it is in other states, but at least here, Narcan is on a statewide standing order to be allowed to be prescribed and dispensed. All right, thank you for sticking through that. We've hit another full section. Hopefully that was helpful. It's a lot. I will let you all know right now. You might be feeling a bit overwhelmed at the moment. But at the end of the day, pharmacy is one of the most regulated professions in the entire country. We have our MPJEs written into law. So as we go through these questions, hopefully you're picking up some questions that you did get wrong. Now you know what the correct answer is. Or if you really wanted to dig deeper into the wording of the WAC or RCW, we provided those here. Let us take a quick 10-minute break. So it is currently 1:13. Let's all return at 1:23, and then we will jump into the final section for today. And of course, reach out if you have any questions, and James and I will stay on for as long as you all do have questions. But see you all back in 10 minutes.
Get started in another 2 more minutes or so. But again, if you haven't had a chance to stand up, go ahead and do that. Take a deep breath. Almost there. Okay, let's start. Okay, so we are now going to move to round 4, which is the domain related to pharmacy operations. So that includes a lot of different things, including distribution of medications, paperwork, other regulations related to like the business and to the facility itself. So let's get started. So, your pharmacy is working on ordering Opana from a wholesaler. Because the Seesaw system is currently offline, you need to use a DEA 222 form to order this product. Which of these is true about the use of this form? Is it 1, you must send a copy of the whole form to the DEA after the transaction? 2, this form can only be signed by the pharmacy manager before it's released? 3, if there's an error on the form, you must discard the form and use a new one. Number 4, your pharmacy must save a copy of this form for at least 2 years. Or 5, all of these are true. Maybe all just a few more moments. All right, let's take a look here. All right, so the majority of you selected all of these are true, and some of you selected number 4. Number 4 is the correct answer. So let's talk about why some of the other answers are incorrect. But first, even taking one more step back, so this medication, Opana, is a Schedule II controlled substance, also known as oxymorphone. So being a Schedule II, you would have to use a DEA 222 form or an electronic equivalent, also known as the CSOS. Now, if the electronic equivalent is not available, then you would need to use a paper form to order the product. Now, the DEA 222 form, in our state, we follow the same laws as the federal laws. So there are specific things we can and cannot do with regards to this form. Um, First of all, what happens with the form? Remember, if you are purchasing something, the purchaser would save a copy for themselves and they would send the physical form to the supplier. I like to use like a prescription almost like as an analogy in a way where, say, if a patient is dropping off a Schedule II controlled substance prescription, they would drop it off to the supplier of the medication. Um, so you as the purchaser, you have to keep a copy, and that copy you would have to keep for at least 2 years. The supplier would then double check the form, make sure it's valid. And if it is valid, then they can supply the medication to the purchaser. And then they send a copy of the form to the DEA. A few other things, the DEA 222 form may never, ever, ever be corrected. You can't cross things out, you can't erase things. That would invalidate the form. If there is an error, you should void the form and keep that voided form for at least 2 years. You should never ever discard or destroy a DEA 222 form. They have serial numbers and the DEA keeps track of those. Another thing, the person who signs a DEA 222 form should have power of attorney. Your position in the pharmacy does not necessarily correlate with whether you have power of attorney or not. That has to be granted to you by the registrant. So most pharmacists and pharmacy managers would have it, but just because you are a pharmacist or a pharmacy manager does not necessarily mean you have power of attorney. In addition, technicians, non-pharmacy personnel technically can get power of attorney to order Schedule IIs as well. It just depends on the registrant, and it's under the registrant's responsibility to choose the right people. So in this case, with regards to signed by the pharmacy manager, it's not a requirement at all. And sending the form to the DEA after the transaction, no. A copy will be sent by the supplier to the DEA after the transaction. All right. Yeah, I do recommend study the different DEA forms, how they're used and stored. So things like DEA 106 versus 41, how are they used? The 224, 225 forms, 363. There's a bunch of DEA forms, and you'll see most of those on the DEA manual. All right. So next we have a DEA agent who is coming to do an inspection or audit. Which of these is not a rule that the pharmacy is required to follow for the records? So is it that records are readily retrievable within the last 2 years? Controlled substance records must be kept together, but also separated from regular prescriptions. Records of transfers may be maintained with prescription records. Schedule 3 to 5 controlled substances may be kept with regular prescriptions with a recognizable method. So again, which of these are not a rule that the pharmacy is required to follow? I should note a thing about number one too, where it says readily retrievable. What readily retrievable practically means is during that inspection, you should be able to pull up that record. You can't just submit it afterwards. That would not be considered readily retrievable. Okay, let's see what you all answered. All right, a good mix here. So the correct answer here is 2. Or more specifically, the answer that is not a rule that you're supposed to follow would be number 2. And why is that an incorrect answer? Because when it comes to controlled substance records, there is some separation that has to be done. Specifically, your Schedule 2s have to be separated from your 3 through 5s. Now, the 3 through 5s can be kept together with regular prescriptions as long as they are marked and readily retrievable. But the Schedule 2s have to be put separately. So this is just a visual of what that would look like. All right, next question. Which of these are you not allowed to do with your IV ondansetron vials in your hospital pharmacy? So are you not allowed to, 1, sell a few vials to a nearby unaffiliated veterinary clinic for an urgent need? 2, move your entire stock of IV ondansetron from one of your satellite pharmacies to the main central pharmacy? 3, redistribute the IV ondansetron vials among the other pharmacies in your hospital system. 4, form a relationship with a nearby skilled nursing facility and supply them with ondansetron for their emergency kit. Or 5, become a nearby clinic's primary supplier of IV ondansetron to save them money. So which of these are you not allowed to do? So it's a question of medication distribution. Oh, and I realized I didn't activate the poll yet. Sorry. Give you all a few more seconds. All right, let's take a look. Excellent. Number 5 is the majority answer, which is also the correct answer. So this goes back to that concept we talked about earlier. So when it comes to you as a pharmacy, regardless of whether you're a hospital pharmacy or community pharmacy, there's a distinction between dispensing medications to patients versus dispensing medications to non-patients, aka clinics, to practitioners, or other facilities. You are allowed to sell medications to non-patients, but you have to follow that 5% rule and also meet the urgent need. So those are the two pieces that you need to do to be able to sell medications to non-patients. So number 5 is something that is not allowed because um, this is not for an urgent need. And if you're being their primary supplier just to save them money, that's not a valid reason to just sell a medication to a non-patient. Your primary role as a pharmacy is to dispense and administer medications to patients, not to non-patients. In terms of the other items, those would be allowed. So if you're selling a few vials to a veterinary clinic for an urgent need, that's totally fine. If you are selling to something within your organization under the same ownership, you can transfer medications however you want. So you can move your entire stock of IV ondansetron to your satellite pharmacies, to the main central pharmacy, to other pharmacies in your hospital system, as long as you're all under the same ownership. That is totally fine. If you work with a skilled nursing facility, you don't necessarily have to say, quote, form like a formal relationship, but skilled nursing facilities need to have an emergency kit. So a pharmacy can supply medications for a skilled nursing facility's emergency kit. Though do know in this case, if you're supplying medications for an emergency kit, the medications that are inside that kit are technically still under the pharmacy's responsibility and under the pharmacy's ownership. It isn't until it's pulled from the emergency kit that is now under the ownership of the skilled nursing facility, even if it's all physically on site. So here are the kind of a summary of what we just talked about. So emergency medical reason, and then the 5% rule. Our state specifically, the 5% rule is a drug dollar value 5% rule rather than a unit dose, how many tablets. So we look at the gross dollar value being less than 5% of your total drug revenue in the last 12-month period. Now, there are some exemptions. We talked about being within the same company. If you are permanently closing your facility, so say like a Rite Aid's permanently closing, then that would be an exemption to this. Sale of blood products probably won't show up on the MPJE, but just to let you know. And then items that are not considered a sale, meaning the product is still under the ownership of the pharmacy, like an emergency kit. All right, moving onwards. Your pharmacy is looking to provide point-of-care influenza testing. Which of these items does your pharmacy need to have to provide the service? Do you need a registered nurse to administer the test? Do you need a CLIA certificate of waiver? Do you need a modified pharmacy license with testing endorsement? Do you need a state or federal vaccination certificate? Or do you need an ancillary utilization plan? So which of these do you need to provide this service? I know point of care testing is becoming a big topic nowadays, so this is probably going to continue to evolve as things continue moving forward. All right, let's see what you all answered. All right, so the majority of you selected a CLIA certificate of waiver, and that is the correct answer. Now let's talk about the other choices real quick. Number 1, you don't need a registered nurse to administer the test. Yeah, could you technically hire a registered nurse and have them under contract to do that? Yeah, technically, but it's not at all a requirement. A modified pharmacy license with testing endorsement. That doesn't exist, at least in our state. So that's not something you need. A state or federal vaccination certificate. So there's a difference between influenza testing versus giving a vaccine. Remember, if you are giving a vaccine, you have to be certified and you have to have it listed under your CDTA to prescribe a vaccine. But that's not necessarily the same thing as doing influenza testing. Ancillary utilization plan. So an ancillary utilization plan, again, is a document that your pharmacy needs to have to be able to have pharmacy technicians and assistants in your pharmacy, and describes what they can and cannot do. This doesn't necessarily have anything to do with influenza testing. So with regards to the CLIA waiver, that is what you do need to be able to do to be able to have point of care testing. The main concept is this. If you're doing any sort of lab test, including influenza testing, you either have to be a clinical laboratory or you would have to apply for a CLIA waiver to be able to provide lower risk tests and have it waived from you needing to be a clinical laboratory. So that's kind of the idea. So there are certain tests that you can apply for on your CLIA waiver that are considered low risk and allow you to provide those in a non-clinical laboratory setting. One important thing to know is you have to follow the manufacturer instructions exactly with no modification to be able to do point of care testing. All right. Moving onwards, you are a pharmacist consultant doing an audit of medication storage at a resident care unit in a skilled nursing facility. Which of these would be considered acceptable forms of storage? Would it be storing the emergency kit underneath the front desk for accessibility? Would it be storing medications on labeled trays inside patient rooms? Would it be storing insulin pens in a refrigerator located in the locked staff break room? What about Schedule 2 controlled substances stored in a separately locked cabinet with keys for only the charge nurse? Or would it be an LPN, licensed practical nurse, keeping a blister card of acetaminophen on hand in case a PRN order is requested? So which of these is acceptable? All right, let's take a look and see what you've all answered. Okay, number 4 is the choice. Schedule 2 controls are stored in a separately locked cabinet with keys for only the charge nurse. Indeed. Now, it doesn't have to be stored that way, but the key point is the fact that the Schedule 2 controlled substances are in a locked location and only specific people have access to the medications. So most of the other choices there, emergency kits, inside patient rooms on labeled trays, those would not be correct because this can potentially lead the public to having access to legend drugs or controlled substances. So that's not allowed. They have to be secured in some way, shape, or form. Refrigerator located in locked staff break room. How do you know that that refrigerator is not used to store food as well? You can't store food inside the same refrigerator as medications. And then keeping a blister card of acetaminophen on hand. That is just improper storage of medication. You can't just have it traveling along with them just in case an order is requested. And what if they forget to put it back into the storage kit? So this is kind of a summary of the answer choices we just talked about. So the main idea again is you have to store medications if it's outside of a pharmacy setting in a secure way and also in proper conditions as well. All right, Next question. What about this? Which of these is true about the unpacking of a tote of hazardous drugs that was just received from a supplier? So, can you unpack in the sterile compounding area, or does it have to be? That is, does it must be completed in the sterile compounding area? Number two, minimum PPE required by USP for unpacking an undamaged tote is a disposable gown, face mask, and 2 pairs of chemotherapy gloves. Three, the room in which the unpacking happens must have positive pressure. Four, if there are signs that the product inside is damaged, unpacking must happen within a PEC or containment primary engineering control. Four, items that seem dirty should be rinsed with potable water before they're stored on the shelf. Which of these is true? Okay. So let's take a look and see what the thoughts are. Okay, the majority of you selected four, and that is the correct answer. So this, when we're talking about hazardous drugs, we're talking about USP 800 and the USP guidelines related to that. So a few things. Let's kind of go down one by one. So number one, unpacking must be completed in a sterile compounding area. Well, that would, if you were to unpack a tote in a sterile compounding area, you're essentially contaminating the whole area. So that would never be a good answer. Number two, with regards to PPE, now your facility may choose for you to have more PPE. That is totally fine. But in the case of what's required, you really just need 1 pair of chemotherapy gloves when it comes to unpacking a tote of hazardous drugs, unless the tote is damaged or shows signs that medications are leaking in there. Number three, regarding the unpacking, remember when it comes to hazardous drugs, unpacking, compounding, all has to happen within a negative pressure room. And what that means is air is being sucked into the room and potentially being vented out. But basically, the idea is you don't want the hazardous drug to, or any of the pieces of it to really get into any of the other rooms. If there are signs that the product inside is damaged, unpacking must happen within a CPEC. So what is a CPEC? That is a containment primary engineering control, aka a hood or some sort of a device that would contain the product to prevent any of hazardous like residue from getting outside of that device, essentially, to protect the rest of the room from the product. Number five is incorrect. If it looks dirty, you don't rinse it with water. If it's a hazardous drug, you have to deactivate it with a deactivation item and make sure to clean it. So that was a lot of pieces. So the main point is we're talking about USP 800. In our state, when it comes to USP 800, enforcement of the rules, specifically it has to do with compounding. But do know that in your NAPLEX and MPJE, USP 800 can be asked. So there can be details regarding USP 800 in addition to that USP 797 and 795. And I think in the next 1 or 2 questions, we'll have a USP 795, 797 question as well. All right. Next, if a hospital does not have a pharmacist on site 24 hours a day and the facility needs to obtain medication from the pharmacy when it's closed, can the hospital designate a staff member to obtain medications from the pharmacy? Yes or no? You have a 50-50 chance here. All right, let's take a look. All right, the majority of you say yes, and that is indeed the correct answer, assuming you have a policy for that. So, who is allowed to enter a pharmacy? In general, pharmacists are the only ones allowed to enter a pharmacy independently. Everyone else, including technicians, interns, non-pharmacy staff, must be immediately supervised by a pharmacist. But there is also an exception. When there are no 24-hour pharmacy services in a hospital setting, meaning there's no pharmacist on staff, your hospital may designate through their policies and procedures to allow a non-pharmacist to enter the pharmacy to obtain medications, really more on an urgent basis only. So they don't spell it out specifically in regulations, but in general, you only remove the medication that you really need. You leave the remaining stock bottle there so they can review it in the morning, and that order should be accessible so the pharmacy can keep track of what happened. And again, this can only be done in, say, like a hospital setting where there's no 24-hour pharmacy services. So this wouldn't happen in, say, a community pharmacy. It's really only in that setting. All right, another question. You are a new pharmacy manager and you're conducting your first controlled substance inventory. To make sure that you're completing this correctly, which of these must you do to meet state and federal requirements? Do you have to complete it during business hours while the pharmacy is staffed? Do you have to complete the inventory and submit that inventory to the DEA and keep it on file for 2 years? Do you have to include items that are packaged as complete prescriptions ready? So completed prescriptions, do those have to be included on your count, essentially? Does this inventory have to be completed in the month of March? And does the inventory have to be completed by the pharmacy manager? So which of these has to be done to meet state and federal requirements? Alrighty, let's take a look here. Alrighty, so the majority of you selected 2. Completed inventory must be submitted to the DEA and kept on file for 2 years. That is actually incorrect. The correct answer is number 3. Inventory must include items that are packaged as complete prescriptions ready to sell or dispense. So essentially, when we're talking about controlled substance inventory, we're talking about this biennial inventory or the complete count that is done in certain other conditions as well. One of which is, per our state, if you change pharmacy manager or pharmacist in charge, then you have to do a controlled substance inventory. With regards to what you count, you have to count every controlled substance in your pharmacy. And that includes prescriptions that are ready for pickup in the will call. It includes medications that are packaged, ready to be sent back to the supplier. So if you're doing a return, those all have to be counted. Anything that's on site, those have to be counted as part of your controlled inventory. Now let's talk about the other choices here. So number 1, completed during business hours. So it has to be completed when the pharmacy is closed. Now, if you are, say, a hospital, your hospital may never ever close your pharmacy. So you kind of do your best, essentially, with regards to that. But just to be very clear, the DEA's requirements is that it has to be when the pharmacy is closed. Number 2, completed, submitted to the DEA, and kept on file for 2 years. So the keep on file for 2 years is correct, but you don't submit that inventory to the DEA. When they inspect or audit you, and when the pharmacy commission audits you, they will check to make sure that you've completed that, but you don't submit it to the DEA. completed in the month of March. So that's incorrect. You might be thinking about the self-inspection of the pharmacy. That is something that has to be completed in the month of March, but it's not something that the controlled substance inventory has to be done in the month of March. And then completed by your pharmacy manager, that's not a requirement via a state or federal law. Now, your company may require you to do that, but it is not a state or federal requirement to do that. So yeah, so when it comes to the controlled substance inventory, I think it's important to just double check some things, like when is a controlled substance inventory required? There's a specific WAC that specifically says when that is required. Highly recommend look into that. What items can you estimate? So remember, certain controlled substances you can do an estimate, while some you have to do an exact count. So which of those items can you do of which? And I'll also say, be able to recognize if they show you a picture of a controlled substance inventory, does it look complete? Does it have all the pieces that are necessary in the controlled inventory? All right, moving forward, we have another question. We have a patient who's currently sick and asks your pharmacy to see what options they have to obtain their Paxlovid that's currently filled at your pharmacy. Which of these are not valid ways to deliver the medication? So one, patient requests their neighbor pick up the medication and bring it back to the patient's residence. Two, a pharmacy staff member drops off the medication to the patient after work. Three, the medication is mailed to the patient through a local mail service. Four, the medication is delivered to the patient's primary care provider's office, which is within walking distance to the patient to pick up. Five, a common courier picks up the medication and brings it to the patient directly. So this is a question about prescription delivery. When I think about this question, I think back to the pandemic, or just the times when patients come in sick, coughing and hacking to your pharmacy. So a lot of pharmacies definitely started developing a delivery service to ensure patients can get their medications. All right, so let's see what your answers are. Okay, so which of these are not valid ways to deliver the medication? So the majority of you selected two. The correct answer is actually four. So medication delivered to the patient's primary care provider's office for the patient to pick up. And why is that the case? Well, so essentially the main idea is with regards to delivering medications or pickup of medications. First of all, the patient or they can designate an agent to pick up the medication for them. That is allowed. But if they or their agents cannot go and pick up their medication, then there are delivery options. So either a pharmacy staff member can deliver the medication directly to the patients, as long as it is within their scope of practice or scope of their job employment. They can use a mail service such as USPS, FedEx, or some other mail service. Or they can use a courier service such as a common or contract courier. AKA, there are certain like med delivery services that are out there that you can contract with. You could use Uber Eats. They technically fall under that category as well. Now, it's important that you choose wisely because you want to make sure the patient's privacy is maintained and that the medication actually gets to the patient. It is your responsibility as a pharmacy to ensure that whatever delivery method you use ensures the medication gets to the patient, or you, the pharmacy, could be liable for choosing a poor choice. Now, why is delivering the medication to the primary care office not valid? Because the primary care office is not the patient's agent. And if you deliver it to that office, there's no guarantee or control to ensure that the patient actually gets the medication from there. And you're essentially delivering a legend drug to someone who shouldn't have access to the medication. So that's why delivering to the primary care office is not valid. I also mentioned at the bottom, controlled substances are even more strict. Specifically, the medication must be picked up or delivered to the ultimate user. So basically, the patient or someone in their household, aka living in the same address. So the patients can't necessarily designate just their friends to pick up a controlled substance prescription. Now, does it happen in real life? Yes, but just know the DEA regulation says it has to be picked up by or delivered to the ultimate user. All right. Next question. You receive a prescription for Lantus. The patient's insurance doesn't want to cover it, but they will cover Semglee. Which of these would be true about this substitution per Washington state law? How many of you have seen this situation happen? So, number one, this substitution requires a new prescription from the practitioner. Number two, the practitioner would have to be notified of this substitution within 5 days. Three, this substitution can only be done at certified specialty pharmacies. Number four, the substitution requires the pharmacist to have a CDTA. And number five, the pharmacy would need to certify that Semglee and Lantus are generics of each other. Which of these is true about this substitution? All right, let's go and take a look. So this is a question all about biologic substitution because Lantus or insulin in general are considered biologic medications. So our state laws do say a few things about biologic substitution. One of which, number two, the provider would have to be notified of this substitution within 5 days. If I'm correct, I need to double check. This rule has been extended all the way to 2028, if I'm correct. But I have to double check that date. Pharmacies are allowed to do biologic substitution. And one question you're going to have to ask in terms of this is Semglee and Lantus substitutable with each other? The resource you would use to do that is the Purple Book. The reason why number five is incorrect is more so terminology. Generics is not the right term for biologic substitution. More specifically, the term is biosimilar, not generics. Some of those other choices, so certified specialty pharmacies, no, you don't have to be a specialty pharmacy to do biologic substitution. The other two, 1 and 4, are implying essentially that this substitution is not allowed, and then you would have to get either a new prescription from the practitioner or the pharmacist would have to prescribe it. Having a CDTA means we're talking about pharmacists prescribing it. So that is different than biologic substitution. That's actually prescribing something. So with regards to that, Semglee and Lantus are technically considered biosimilars of each other, so they are substitutable. The resource that you would use is the Purple Book to look at that. Just as reference for this case, if you look at the Purple Book, all the different insulin glargines that are available on the market are generally substitutable with each other except for Basaglar. Basaglar is the only one that you can't really substitute for. I should also mention there are other insulin glargines at different concentrations, so those are not substitutable with each other. But the ones that are the U100, Semglee, Lantus, those are generally substitutable with each other except for Basaglar. All right. I wanted to point out there are other substitution rules in our state. So just to point out those differences. So there's generic substitution. So our state requires, and not just allows, but requires pharmacies to do generic substitution, specifically for an item that is considered therapeutically equivalent, meaning it has to have the same identity, same salt, same dosage form, and essentially the same efficacy and toxicity. So for instance, doxycycline monohydrate versus hyclate, they are not the same salt. So that would not be valid for a generic substitution. Tablet versus capsule is technically not also considered therapeutically equivalent. So that is not allowable via generic substitution. Now, the next thing, prescription adaptation, does allow you to change the dosage form. But just to let you know, that's what the generic substitution rules say. So prescription adaptation is a specific regulation we have in our state. Different states have different rules regarding this, but this allows a pharmacist to make certain changes to a prescription. Excuse me. So that includes changing the quantity of a prescription if the package size doesn't exist, or to accommodate a change in dosage form, or to also help line up meds in a MedSync program. In addition, pharmacists may change the dosage form. So again, that's between tablets, capsules, liquid, different dosage forms, not changing the salt, but changing the form of the medication if it's in the best interest of the patient. And pharmacists are also allowed to add missing information if there's evidence to support the change. AKA say there you have access to the electronic medical record, or the patient shows you a MyChart message or something like that, some sort of evidence to support that information, support the change. So those are things you can change. Then there's the category of therapeutic interchange. So this is any changes that are outside of generic substitution and prescription adaptation. So you can do therapeutic interchange. So say from doxycycline monohydrate to hyclate, if you have a CDTA, though that's technically prescribing, not specifically therapeutic interchange. Or if it's allowed per the prescription. So if the prescription says you can make that change, then you can do that. Or if your institutional policy or formulary allows you to do that. And if the prescriber is an endorsing prescriber within the Washington State Therapeutic Interchange Program. So I would recommend look into the Therapeutic Interchange Program and see what the requirements are that. So that's specifically the Therapeutic Interchange Program relates to prescriptions written by prescribers for patients who are on our state Medicaid programs. So they have specific rules what allows you to interchange medications from one to another. So there is a chat message. Does renal dose adjustments qualify as an adaptation? I don't necessarily say that is necessarily adaptation. If it is on the prescription or order that says, hey, you can make a renal dose adjustment, then that is just basically following the prescription. Now, if you are doing it outside of the prescription, then then it would fall under either a CDTA, if you have prescriptive authority to be able to do that, or if you have an institutional formulary policy or agreement that allows you to do that. So that would be therapeutic interchange if you are changing the dose on that. But yeah, that's definitely something a pharmacist can do, assuming permission is given, either via CDTA, institutional policy, or if it's specifically on the prescription itself that says to do that. Boris messaged me about the biologic substitution. So in terms of letting the practitioner know, that's actually only up to August 1st of this year. So not too much longer that you have to let them know for a biologic substitution that was completed. Good questions. All right, let's move onwards. We're almost done. We have a compounded solution of acetaminophen and codeine liquid. Has 100 milligrams of acetaminophen and 20 milligrams of codeine per 5 ml of solution. What schedule of controlled substance would that be? Would that be Schedule 2, Schedule 3, Schedule 4, Schedule 5, or not controlled? Yes, there may be calculations on your MPJE exam. What I would say probably the most likely calculations you would see would be something like this, or like opioid conversions and those kind of calculations, thinking about opioid limits in your state, and in our state, that is. As a reminder for NAPLEX and MPJE, you won't have, say, a fancy calculator. You'll either use the calculator on the screen, which, if I'm correct, is a pretty basic calculator, or they can give you just a basic handheld calculator at the exam room. But don't expect anything fancy. All right, let's go and take a look. All right, we have some good guesses here. We have Schedule 3, Schedule 4, Schedule 5, and Schedule 2. What is the answer in this case? Schedule 3. So let's go through that calculation together. So when it comes to coding, remember the rule related to what schedule it is falling under. So for reference, the formula from this case is up on the top right. But remember, the cutoff points are this. Schedule 5 is basically less than 0.2%. Schedule 3 is anything less than or equal to 1.8%. And then anything higher or schedule or coding as the only active ingredient would be Schedule 2. So in this case, there is both acetaminophen and codeine together. So it's not just codeine by itself. So then the conversion we would have to look at is, what is the percentage? So the conversion for percent solution, remember, is grams per 100 ml. So if we look at those cutoff points, 0.2% would be 0.2 grams per 100 ml, or basically 200 milligrams per 100 ml, which equals 2 milligrams per ml. So anything equal to or lower than that would be Schedule 5. 1.8% would equal 18 milligrams per ml. So anything lower than that or higher than 2 milligrams per ml would be Schedule 3. But anything higher than 18 milligrams per ml would be Schedule 2. So in this case, our formula is 20 milligrams of codeine divided by 5 ml of solution, which is 4 milligrams per ml, which is a Schedule 3 controlled substance. Now, of course, this calculation you can tackle in many different ways. You can calculate the percent concentration of the codeine. So you could do that. Whichever way you go, this is a Schedule 3 controlled substance. So codeine is probably the biggest example of one where the schedule of the controlled substance may change depending on the concentration. There are a few others I doubt they would ask questions about that, like morphine. So I would focus on the codeine calculation. All right, speaking of compounds, your home infusion company compounds injectable hazardous and non-hazardous IV products for patient use. To ensure compliance, what's the minimum required frequency for your compounding staff? How often they have to complete a sterile fingertip test to maintain competency? Is it just once before starting compounding? Is it once every month, once every 3 months, once every 6 months, or once every 12 months? All right, let's go ahead and take a look at your answer choices. All right, so once every 6 months, and that is the correct answer. So this is a USP related training question. So again, our state requires for all compounding that we follow the USP guidelines. So with regards to training competency requirements, there are multiple requirements, and this is split out USP 795, 797, and 800. General competencies like cleaning, sanitizing, handling is initial and every 12 months. PPE, cleanliness, garbing, hand hygiene, initial and every 12 months. But for sterile compound, USP 797, that is every 6 months, which includes things like a media fill test, aka going and doing a compounding a fake product using media and see if anything grows in there. Fingertip sampling. So after you do your garbing and gloving, they'll have you put your hand on a petri dish and see if anything grows from there. And they'll also test the surface as well to make sure you're not contaminating the surface. Now, these frequencies can potentially change if you are doing category 3 controlled substance, not controlled substance, sterile compounding, that is. So as a reminder, USP updated their standards. So now we look at compounding with relation to the category. So there's category 1, 2, and 3. Category 1 is done in a segregated compounding area, aka a non-clean room. So you could put like a hood inside just any regular room and compounds in there. That would be category 1. Category 2 is within a clean room suite, and category 3 is within a clean room suite plus additional requirements. What category 3 allows you to do is extend the beyond use state of a compound. All right, a lot of details. Now, moving forward, you are a central fill facility for a few pharmacies in your chain. In your queue is a prescription for Lyrica 50 milligram capsule. Assuming your facility does not have policies preventing this item from being centrally filled, which of these is true about this transaction? So again, you are a central fill facility. So central filling is not considered a prescription transfer. Number 2, the medication must be delivered directly by your central fill pharmacy to the ultimate user. 3, the central fill prescription order may be transmitted to the central fill facility by verbal method, fax, and electronically, though electronic is preferred. Number 4, the label of the product must have the address of the central fill location. Number 5, none of these actually apply because this medication legally cannot be centrally filled. So this is a question about central fill. I should mention, as you're studying for this, there are both Washington state and federal requirements. There is a section on the DEA manual for controlled substances related to central filling. I guess that eliminates number 5 right there. But so there are specific requirements to look into, and I recommend looking into some of the definitions and what a central fill facility is and is not allowed to do. All right, so let's take a look at some of your answer choices here. So which of these is true? So the majority of you selected 1, and that is indeed the correct answer. So let's talk about this. So remember, a central fill facility, who do they serve? A central fill facility serves pharmacies. So they help a pharmacy fill and process prescriptions. But because they serve pharmacies, they are not allowed to dispense medications directly to a patient. They have to dispense to the home pharmacy. That is a key point of central filling. So that is why number 2 is incorrect. Even if it's a controlled substance, they deliver to the pharmacy who dispenses the medication to the patient. Now, with regards to the other pieces. So 1 is true because central filling is not considered a prescription transfer. That is one of those exceptions in a way to the rule. Other pieces, central fill transmission. So if you're transmitting an order to a central fill facility, electronic is preferred, but it is not required, but you can't do it verbally. In addition, the label of the product, it's you do not have to have the central fill pharmacy's address on the label of the product that's being dispensed. There has to be some sort of a marking, either like a code number, a DEA number, something to know that it was filled via central fill, and for the pharmacy to be able to identify where it came from. But you don't have to have the full address of the central fill location. I guess another key point is the label of the product that goes out to the patient should have the home pharmacy's information, not the central fill location. And as we mentioned with number 5, controlled substances are allowed to be central filled. Now, most companies decide not to do that because of the extra liability, but it is legally allowed to centrally fill controlled substances, including C2s. All right. So I should amend C real quick. So yeah, a C, and then that's actually our state regulation. So our state only allows prescription information to be transferred electronically for central filling. Fax is allowed federally, but not in Washington state. There's some tips on the side for central fill. So again, they can't dispense directly to patients. The central fill facility in our state has to share a common electronic system with the originating pharmacy. There has to be some sort of agreement between the home pharmacy and central fill. You have to have SOPs or policies and procedures related to central filling. Controlled substances are okay. Vials have to have the home pharmacy information on them, and records have to be kept on both sides. All right, next question. You are excited to move your independent pharmacy into a new higher volume area within a shopping center. How does this movement affect the licensing of the pharmacy? So do you have to apply for a new initial pharmacy license? Do you have to file for a transfer license to NABP before moving? Do you have to pay a renewal fee before moving? Do you have to apply for an address change before moving? Or can you just move without completing any of the above? So this has to do with licensing of a facility. Okay, let's go and take a look. All right, so the majority of you selected 4, and the correct answer is unfortunately 1. So what is this all about? So the main idea is for your pharmacy facility, if you are moving address, anytime you move an address, you need a new license. So you have to apply for a new pharmacy license. All the other mechanisms, they don't exist. So the key point again, if you are a pharmacy facility and you are moving to a different location, even if it's next door and you're changing your address, you need a new license. You have to apply for a license. Now, they may give you the same license number at the end of it, but you have to apply completely new. You have to be inspected. All those requirements have to be done. So the transfer license through NABP, no, that doesn't exist for pharmacies. It does for pharmacists and pharmacy personnel. Renewal fee, no. Apply for an address change, no. I mean, maybe in a business sense, for business licensing you would, but for pharmacy related stuff, you have to apply for a new license. All right, almost there. Pharmacy physically located in California has a non-resident license in Washington state, and they're due to have their license renewed. Which of these is not true about this California pharmacy's renewal of their non-resident license? Do they have to be re-inspected? Or again, which is not true? Which of these choices is not true? They need to be re-inspected within 2 years and submit an inspection report. They have to renew their non-resident license every 2 years. They must maintain their California license. They would have to apply for a new license if their address changes. They must list all pharmacists who are employed and submit it yearly. So which of these is not true? So just as background, a non-resident license It's specifically in reference to a pharmacy that is located outside of our state, but does business within our state. So they serve Washington State patients. And do note, if you are, say, a pharmacy from out of state, but a patient is just traveling to the other state, you don't need a non-resident license for that, just for a one-time thing. It's more so if that is part of your business model that you serve patients within Washington State, then you would need to have a non-resident license. Alrighty, let's take a look and see what the answer choices are. Okay, so which of these are not true? The majority of you selected 5, and the answer is 2. Now, why is number 2 not true? Well, here's the thing. Your renewal, as we mentioned earlier, for facilities happens once every year, not every 2 years. So that is why that is not true. But you do have to renew your non-resident license, and there are certain requirements that go into that. So in terms of the renewal, one of the things is you have to be re-inspected and submit an inspection report. That is something that is required. You must maintain your original license, aka your California license. If your license address changes, just like we talked about in the previous question, you would have to apply for a new non-resident license. As part of the application process, you have to list all pharmacists who are employed and submit it yearly as well. So those are all things you have to do as a non-resident pharmacy. So that's just a summary of what we have here. A point about that inspection program. So the Washington State doesn't have to be the one inspecting the non-resident pharmacy. An out-of-state inspection program can inspect them, but they have to meet equivalency standards. So basically, Washington State has to approve that inspection program. They do have a list online of which states fall under the approved inspection programs. But if not, NABP also has an inspection program as well. Now, that's not something that I would say which states are approved or not. You would have to memorize, and it does change quite often as well. And here's just some information about non-resident pharmacies. So that includes things like being fully licensed within the state you operate, having a toll-free number, following the same medication record and counseling requirements as Washington pharmacies. One thing to note, staff working within the non-resident pharmacy don't have to have a Washington State license. But again, you still have to have a list of pharmacists who practice within that non-resident pharmacy and send that to the Pharmacy Commission. So Boris put out a message saying a lot of the questions regarding facilities come straight from the Department of Health website. Absolutely. So there's a lot of good information on there regarding facilities. I recommend also going through a lot of the frequently asked questions on there, because that can help clarify a bunch of details related to pharmacy and pharmacy facility practice. All right, got another question here. So say you are a community pharmacy and you do non-sterile compounding. So you also make hazardous drugs. Which of these is false about your self-inspection that you have to do by the pharmacy? So number 1, does that have, again, which of these is false? So is it completed by the responsible pharmacy manager? Does the pharmacy have to complete a general self-inspection, USP 795 addendum and USP 800 addendum? Does it have to be completed a minimum of every 2 years? Does it not have to be submitted to the Pharmacy Commission? Does it have to be done if a new pharmacy manager is assigned to the pharmacy? So which of these is false? So as you're answering this question, so this is one of the concepts that specifically applies to our state. Now, many other states are implementing this type of self-inspection thing as well. But basically, pharmacies have to complete a self-inspection at specified time periods, which we will answer through this question. But it is something that that we have to do for all pharmacies. All right, let's take a look at your answer choices here. So which of these is false? The majority of you selected 3, has to be completed a minimum every 2 years, and that is indeed false. So a self-inspection actually has to be completed a minimum every 1 year. And not just 1 year, but it has to be completed in the month of March every year. And in terms of the self-inspection, there is a worksheet that you have to go fill out. I highly recommend looking into those. Those can also be very good study resources as well. A few things to know, this self-inspection worksheet has to be completed, but doesn't have to be submitted to the pharmacy commission. It has to be completed by the pharmacy manager. If a new pharmacy manager starts, then you have to do another self-inspection at the time of when they start within 30 days. And then there's a general self-inspection or a general hospital self-inspection worksheet that has to be done. Then if your facility also does other things like compounding or uses hazardous drugs or compounds hazardous drugs or serves long-term care facility, then you also have to complete an addendum in addition to the general self-inspection as well. Note that if you practice in nuclear pharmacy, there are certain pieces that may not necessarily apply to you. So certain things may potentially be exempt based off of that. I would recommend at least take a quick glance at nuclear pharmacy rules. It's not something that is mentioned very much, and probably low likeliness of appearing on the exam, but just something worth being aware of. Nuclear pharmacy does have specific rules, and there are regulations related to what you have to do to be a nuclear pharmacist, and what a nuclear pharmacy can and cannot do. All right, I think this is our last question now. Which of these is the Pharmacy Commission not able to administer as discipline towards a pharmacy for failing to meet regulatory requirements? So can they revoke the pharmacy's DEA registration, or can they not, I guess? The second thing would be require the discontinuation of founding, suspend the pharmacy's operation until a deficiency is fixed, require the payment of a fine, or require the changing of the pharmacy manager. So which of these is the Pharmacy Commission not allowed to do as discipline? All right, give you all a few more moments to select an answer here. Alrighty, let's go and take a look and see what you all answered. Okay, so the majority of you select revoke the pharmacy's DEA registration. Indeed, the Pharmacy Commission can't revoke the pharmacy's DEA registration. That is specifically for the DEA themselves to revoke. Now, it is the Pharmacy Commission does work with the DEA, so they can recommend to the DEA to have your DEA registration revoked, but that power itself is specifically in the DEA. So this is a question about what is within the scope of practice of the Pharmacy Commission. That has to do with pharmacy practice and what guardrails they have. So the discipline can really only be based off of pharmacy practice and specifically things that they license. So they can require the pharmacy to discontinue compounding. They can require the changing of the pharmacy manager and say, hey, this pharmacy manager can no longer operate here. It can require the payment of a fine. It could also suspend the pharmacy's operation until a deficiency is fixed. Similar to personnel as well, the pharmacy commission can really only affect things within pharmacy practice. All right, so we've gone over a lot of different concepts today, many, many, many different concepts. So first of all, I want to thank everyone if you have to hop off for attending this session today. Um, we open questions to anyone. Please send us questions via email. We're also going to take questions here in just a moment as well. But we'd love to hear from you. We'd love to hear whether this was useful and helpful for you all. We'd love to hear about how we can improve, and also, any suggestions for future things. We want you all to pass the MPJ, and we're here as a resource for all of you. So please, take advantage of us. Let us know if you have questions. If you need further meetings, I'm happy to meet with you individually for a little bit of time, or answer email questions as well. So please reach out to us. But otherwise, with regards to that, what questions can we answer for all of you for anything MPJE related?
Yeah, let us know if we need to go back to a certain slide, if maybe we kind of went through it too fast, and now that you've thought of a question, we can do that too.
Did we talk about acceptable changes to C3 through 5s and C2 prescriptions? We did not talk about that today. But as a quick answer, in general for C3 through 5s, you can make pretty much any change to that prescription, assuming you speak to the practitioner themselves. So that is one key point from the DEA. You have to speak to the practitioner verbally to be able to make a change to a C3 through 5 prescription. And you can change pretty much anything. You can almost even assume it as, say, like taking a new verbal prescription in a way. C2s in our state, and it's probably going to be fluid year after year after year, though it hasn't really changed in the last few years. So for C2s, specifically what is allowed to be changed is specifically the items listed on the prescription adaptation. So prescription adaptation allows, again, the change of the dosage form of a medication, the quantity, and fill in missing information if there's evidence to support that change. Our pharmacy commission had a specific announcement saying that you can make those changes as long as you speak to the practitioner themselves. Now, there are a few restrictions, though. The DEA has certain things that can never, ever, ever be changed or added to a prescription, or a Schedule 2, that is. They consider those the essential elements of a controlled substance prescription. So that includes the patient name, the prescriber name and their signature, and the medication name. So those three items can never, ever be changed on a Schedule 2 controlled substance prescription, even if the practitioner says it's okay. All right, so for prescribing authority, would CNM come up in the MPJE? Oh, that's a good one, yeah. I had seen CNM prescribing opioids as well, but they're not in the list on the DOH website. My understanding is they just recently added CNMs on there, but generally what I kind of say with CNMs is consider them similar to nurse practitioners. They follow a very similar pathway to nurse practitioners. What about written and issued date? Oh, sorry, go ahead, Boris.
No, I'm double checking that as well, because I've never heard of a certified nurse midwife, but I know in our state we define them as licensed midwife, and they do have some limitation. So I've in the link we had placed in here earlier, I just put it back in the chat. They're under the list of professions who may prescribe. Again, I don't know if there's a difference between certified nurse midwife or a licensed midwife. But at least for a well, from what I see from our DOH webpage, it's a licensed midwife. So then that's clearly defined on there what they can and can't do.
So yeah, there is a slight difference between a certified nurse midwife and a licensed midwife. One, if you go and actually look up their license on our Department of Health website, they are technically licensed under as a nurse practitioner. So that is the kind of difference between that. So as a nurse practitioner, they generally have prescriptive authority within their scope of practice. So the question about written or issue date with regards to, I'm assuming we're talking about C2s, is a little bit of a controversial one there. I don't think it's specifically defined out whether you can change that on a C2 prescription or not. You could make the argument that that is prescription adaptation. You're filling in missing information. On the other hand, there's also the argument that if it doesn't have a date, it's not considered a valid prescription in the first place, and you can't change it anyways. I don't think there's an exact answer there. I don't know if you have any thoughts on that, Boris. But that's kind of my answer there.
Yeah, I've heard mixed comments. I'd usually, especially with like C2s, right? You're writing for like a 3 month supply in separate ones. If you have legitimate reason to believe that there were 3 different ones written for like a 30-day supply, right? Then of course you can make sure it's written on the appropriate date, and of course you contacted the provider to figure out if that was their intention. But then if you receive 3 for the same day of the same copy, at that point, you would want to use your judgment to be a bit more suspicious about 3 prescriptions for the same medication for the same time period.
I should also say too, the DEA regulations also do specifically call out that it is our responsibility to check for duplicates. So to prevent an accidental duplicate prescription from being prescribed. So if there isn't a, don't fill date on those, then it is our obligation to double check and make sure that those were meant to be like 1, 2, and 3, and then we can adapt the do not fill date on there, or whether those are just duplicates accidentally sent 3 times. So that is required legally for us to check. Show the slide with our emails. Absolutely. Let me scroll back there. Might take a while. What is the next question there? Let's see.
If the prescriber sends a prescription written for the 27th, are we able to call and authorize a change or have it available to fill on the 26th?
That's a controversial one. So my personal interpretation of that is, when it comes to prescription adaptation, what does it allow you to do? It allows you to fill in missing information if there's evidence to support the change. It does not say that you can change the do not fill date on there. So my personal take, at least how I practice, is if they are to try and change that do not fill date, you can't change it. You need a new order for that. Because you're not filling in missing information, you are changing information there. But that's my interpretation of how to kind of do it. If it's missing altogether, then you can add it, because you're filling in missing information. Any thoughts about that, Boris?
Yeah, I mean, again, we're both not lawyers here, so
Yeah.
the rule more or less specifically says complete missing information. But as you said, if the date was already written in there and it's their mess up, then to be on the safe side, right? And of course, like with insurance and everything, then there is a potential for just getting a new prescription.
Hi, I have a question about the drug utilization review one that we did. So I know with like if they weren't available, they have to get a retrospective DUR. within 6 hours of opening. But what about for like if it was an emergency situation, do they need to eventually get a drug utilization review, or is that just you don't need to ever do that?
From my interpretation, no matter what, even in an emergency situation, for whatever the medication is brought out for, whether it's an emergency or just a regular dispensing of a medication, a DUR still applies regardless.
Is it that like 6 hour rule too, or
In
do
the
you know?
situation of an like inpatient, where there's no 24-hour pharmacy service available, then yeah, it's still that 6 hour.
I think it'd be great, yeah, to also double check because there is a specific a WAC that specifically spells that out. Other questions?
Hi, I had a question about one of the questions that was talking about like administering acetaminophen in a long-term care setting.
Mhm.
It was about like midway through, but one of the answer choices just said that if the patient brought their own acetaminophen, the product can then be administered by the RN instead of the item dispensed by the pharmacy. So is that answer choice implying that the medication didn't go through the proper protocols of like being brought to the pharmacy and it being documented as a patient-owned med and then it being dispensed from and it being like stored at the pharmacy? And rather it being like, oh, like it was just kind of at their bedside and they just gave it to them.
Yeah, and I think that's a very good clarification that you asked right there. I think that's probably something we probably could have worded a little bit better, but exactly. So technically, yes, patient-owned meds can technically be administered to them, but there you have to have you go through a process of validation of the medication. So making sure that it is actually what it says it is. Most facilities will also put their own label on top of the medication to meet their standards. And then every single dosing of the medication would have to be basically accounted for to ensure that the patient's not taking medication and the facility doesn't know that that's happening.
Okay, thank you.
Excellent questions. What other questions can we answer?
Something else that I will add on here that may help, it's not a major thing when it comes to studying, is checking out any of the FAQs from the other pages of the other health professions. So as an example, we just got a question the other day about can medical assistants take in a refill prescription, right? Can they phone it in themselves? And that's something that was so asked so much that there was an FAQ published, but on the medical assistant page. So if you, I put the link in the chat, and they specifically, unfortunately, in a very gray answer, say that while there's no specific statute, right? It's not really black and white of what medical assistants can do in terms of calling in a prescription. The way I interpret this is it's very protocol driven. So as long as the prescriber that the MA is working under knows what they're limited to, then it's potentially allowed. But it's one of those things where like our who can prescribe and not prescribe, that page actually doesn't give you a clear answer. But then on the MA's page, it kind of gives you a somewhat clearer answer. So just know that if you do run into a roadblock, see if you can find something on the other FAQ pages, because then they might have a better answer.
All right. What other questions can we answer?
So I've got a question. Not sure exactly how well you can answer it, but I'll just send it out there. So we've covered a lot of like the different, rules and things like that with all the fancy letters and numbers. Is it possible that the MPJE would like ask us to recall the names of some of those rules or regulations?
No, that's actually a very commonly asked question, especially from our out-of-state folks. No, the questions will not ask you to recall a specific section of 1864 or, or a specific whack. But they're more concerned of like when they write these questions, do you understand what, based on what's written in the whack, what the patient safety aspect is, or what the pharmacy or pharmacist or technician is limited to doing? But they would never ask you to recall a specific, subsection of a whack or an RCW or even a CRF. So, and if they did, that'd be pretty apt of them to do so.
Sounds great. Thanks.
All right. Doesn't look like we have any more questions. For those who are still on, again, we may send some follow-up items following this session in case we have any clarifications or things like that. If you haven't already, please do even now register for the event so that way we have your email. So if James or I have anything additional to send out for you all, we do have at least your email to send you any follow-up items or clarifications that we end up getting.
Again, please reach out to us. We're happy to answer questions. So please do. We want all of you to be successful in the MPJE. All right. Well, if that's the case, have an excellent day, everyone. Good luck with your start of residency. We're also proud of you all. Do some amazing things out there and save some lives. But yeah, we look forward to hearing from all of you.
I actually had one more question. Sorry.
Yeah.
Go for it.
Just came to me. Do you have any recommendations on like some resources to provide like practice questions for the MPJE aside from like UWorld or RX Prep?
Yeah, so I've been looking through some of the different resources out there. There are certain books on Amazon that you can look at. We can take this offline. Probably shouldn't be saying specific products on this presentation, but there are certain books on Amazon that you could purchase that have practice questions in them. Um, some of which are more accurate than others. There are certain ones where the accuracy is actually not very good. So I'm happy to kind of point you in that direction. Um, but the one thing that is indeed lacking in our state is just practice questions. So it is something that we're continuing to try and work on. If you want to have individual time or talk to me, I'm happy to also bring you a few just practice questions as practice as well. But there are certain books on Amazon that you can purchase that have practice questions that can be very helpful to review some of the rules.
Yeah, and I know NABP specifically does have, their pre-MPJE and pre-NAPLEX. So in terms of like an official place, definitely see if you can sign up for their pre-exam. Just, at least from there, it is from an official testing location.
We'll say this, a downside of the pre-MPJE though is that if I'm correct, it's less state specific. And in addition to that, you don't get to go back and review your answer choices. They'll just literally give you a score and that's it. So that is one piece to consider with the pre-MPJ and pre-NAPLEX.
Yeah, makes sense. And I think you only get one practice test for the year for the MPJE. I know you have two for the NAPLEX.
Yeah, they are pretty protective of their questions.
Sounds good. Thanks.
All right. Well, otherwise, wish you all the best. Have an excellent day.